Good day, ladies and gentlemen. I hope you enjoyed the features of this unique website as you entered the portal. Thank you for joining us today. My name is Hardik Gandhi and I represent Medical Affairs for Zydus. I will be your moderator for this event today, and it is indeed my great honor to welcome you all for this third edition of Neurospace. Since its inception in 2020, Neurospace has fostered sharing of best practices in the field of neurology. To talk a little bit about the past editions of Neurospace, I am pleased to invite the chairperson of Neurospace, Dr. Arvind Sharma. Please, sir.
Thank you, Hardik. Thank you very much. And it's my pleasure and honor to be here with the third edition of Neurospace, which was altogether started 2 years back, and during the very hard time when we were thinking of that we're going to do the physical meeting for the Neurospace, but the wish for the God was different, and it was the COVID which has hit us. So I would really like to take you back to the first edition 2020, where we did the first workshop, that is the spectrum of neurosomnology. That was the workshop on transcranial Doppler for the neurologist. And I definitely very happy to say that this term, not only alone I have conceived it, but it was the idea with all the Zydus team, which was with us to coin this term, Neurospace. Objective was to share the practice in the field of neurology. And we have 7 countries participated at that time with the 350 participants from Latin America, Africa, and Asia. And deliberation by Dr. Vijay Sharma and Arvind Sharma. Can we go to the next slide, please? And in 2021, we changed and geared up to have the second year with the theme of a spectrum of neuroimaging and neurophysiology. And almost there were 4 speakers, what I remember of, and more than 400 participants from 13 countries. And it was really very, very thankful to all of them who appreciated a lot, and from Latin America, Africa, and Asia. And speakers were from Singapore, Mexico, USA, and India. And we're really thankful to all of them who has given us the enthusiasm for this third edition, which is today going to happen under the aegis of Zydus, that is Office Practice of Neurology. Greater than 500 registration already done from Latin America, Africa, and Asia. And speaker, as you know, there are eminent speakers, 7 speakers from Singapore, Dr. Vijay, Philippines, Myanmar, Sri Lanka, Mexico, and Brazil. They will be the case-based presentation. I welcome all of them, from Dr. Bhimsara from Sri Lanka, Dr. Alessandro from Mexico, Dr. Geronimo from Philippines, and Dr. Thar Thar Oo from Myanmar. It's over to you, Dr. Hardik Gandhi.
Thank you, sir. So thank you for speaking briefly about the theme of this year's event, which is Office Practice of Neurology. Actually, it's a very interesting theme and very unique, I would say, because this is a topic very seldom heard about in neurology conferences. The problem is that neurological complications and neurological disorders represent the second leading cause of disability in the world, which is, followed by cardiovascular diseases. The problem is that because of this high burden of neurological diseases and its complications, the secondary and tertiary care centers are overwhelmed. And as a result, the neurologists are spending a lot of time seeing outpatients. Therefore, we decided that this year's theme should be Office Practice of Neurology, where we will deliberate on common and uncommon presentations in neurology outpatient clinics. And for this, we have an esteemed panel of speakers who will share very interesting cases about these presentations and share their experience with us. So before we begin, let us watch a short AV introducing all the speakers, all the experience that we have lined up for you today. May we have the AV, please? So that is our esteemed panel of speakers for today, and we are sure you will enjoy all these case presentations and deliberations that we have lined up. Our panel of speakers geographically is very varied, ranging from Brazil to Philippines and from Singapore to Mexico. So please put your seatbelts tight and let us begin with the deliberations. So without further ado, let me invite Dr. Vijay Sharma for our keynote presentation on office practice of neurology. Please, sir.
Thank you very much, Hardik. I'm happy that I have been associated with Neurospace right from its inception. When we talked about office practice in neurology, so the truth is, neurologists are very busy in a hospital, and the reason why we are busy is that we deal with most of the emergencies, and we deal with patients, and the emphasis is, if we keep the patient in the hospital, let us finish all the investigations as fast as we can. And then most of the things for neurology, they can be handled in an outpatient clinic. So I'm going to just emphasize that there are a lot of things which we can do outpatient. Not only this is fast, it's done by one person, so it's controlled practice. And also it's very yielding, and it's very rewarding for the patient also when it comes to the finances. So I will first talk about the cerebral ischemia. So I chose particularly cerebral ischemia. The reason was that when I saw the list, there are people who are talking about epilepsy, there are people who are talking about headache, movement disorders. So everything is being talked about, but cerebral ischemia still remains. And people believe that cerebral ischemia, also know that stroke, is a hospital practice. No, it's not a hospital practice. Hospital practice is only for first few days to a week. Deal with the complications, deal with the acute emergency, and then everything else can be done for the patient as outpatient basis. The most important thing when it comes to dealing with cerebral ischemia or stroke is just know what is the mechanism. That's the most important thing, because the mechanisms are very simple. Either it is an embolization, whether coming from the heart or artery to artery embolization, or it's hypoperfusion, or it's a combination of two. And once you know the mechanism, everything becomes very simple to treat. Because if it is embolism, don't talk about increasing perfusion, then you talk about how to reduce embolism. Whether you are talking about antiplatelet therapy, anticoagulation, or statins, or a combination of all these things. When it comes to hypoperfusion, yeah, this is very difficult on outpatient basis. What you can tell to the patient is just maintain aggressive hydration. People believe that coffee and cola drinks, they usually increase the blood flow to a small extent. Or if it is a combination of embolism or hyperperfusion, that means you need to deal with the two conditions together. So let us start with first case. This is a 64-year-old man, a routine stroke patient, multiple risk factors, presents with recurrent episodes of right-sided weakness during past 1 week. His CT scan was normal, but then he developed confusion during past 2 days, and that was what it brought to the hospital, and somebody did even an MRI. When we looked at the MRI, this is what we saw. This is all outpatient basis. That MRI shows multifocal strokes on both sides. The MRA does not show any large vessel disease. So the next question is from where the strokes are coming. Definitely they are not coming from the carotid arteries. They have to come either from the arch or from the heart. So accordingly, 24-hour Holter monitoring was normal. The 2D echo was normal. Ejection fraction was 50%. As we expected, carotid duplex did not show any stenosis. We did a TCD, there was no stenosis. But the diagnosis was clinched on an outpatient basis. We were failing to understand what has gone wrong with this patient before we went to the TCD machine, and we just looked at one trace, this trace. We missed, during 48 hours of Holter monitoring, we did not pick up any arrhythmia for this patient. We were looking for atrial fibrillation. And this was one trace of TCD which picked up, and what we were taught in third year, irregular pulse. So what you're seeing here is the pulse is irregular in rhythm, and every cardiac beat which you are seeing on transcranial Doppler in the middle cerebral artery, it's having a different volume. So this is a true representation of irregular pulse of atrial fibrillation. Once you know the diagnosis, everything becomes very easy for you to understand and treat. You just put this patient on anticoagulation and you have won the battle, all at outpatient basis. Let us move to the second case. So this is a younger patient, a female. She was a teacher. No risk factors at all. You don't expect at 34 years any risk factors. She came with one transient episode of speech difficulty when she was teaching the students. She said that somehow she could not bring out the correct words to her students. It was very transient and she forgot about it. But then in the evening, she had another episode where she felt the right side was weak and there was some kind of non-specific giddiness. In the history, nothing was specific except that she had just returned back from work, from an overseas trip. And she was having some work-related stress. All of us, we have some stress especially when we go back to work after a holiday. She was known to have migraines the frequency was not very bad, occasional migraines. But the only thing was some of the migraine episodes, they were associated with visual aura. So we said, okay, let us see. There are so many information in this patient's history. Let us see what we can find. We expected neurology examination to be normal. Her MRI brain was normal. Angiogram was normal. Duplex study was normal. We did a TCD monitoring looking for spontaneous emboli. No, there was nothing. All the blood tests came out as normal. Her lipids were normal except LDL was 3.2. If she did not have this history, 3.2 will be passed off as normal and just say the dietary precautions. But once you know that there was something, a TIA-like episode, then 3.2, you start treating it. The question is, what is happening to this patient? We thought they are young patient having migraine also. Let us do a bubble test and find out whether she is having a right to left shunt. Now, this is a test which is done in office practice. You don't need to admit this patient for this test. What you're seeing in this one is these two are the middle cerebral arteries on right and left side. This is for TCD. This is a combined picture. This is the 2D echo, apical chamber view. This is the right atrium, this is left atrium, and this is the left ventricle. This is the arm of the patient with antecubital vein having a plug connected with a tri-way cannula. This screen which you are seeing, patient is facing this screen. He is going to blow this through this tube like a spirometer. He will see how much pressure is there. So what we are going to do is we are going to shake 9 ml of saline and 1 ml of air plus few drops of patient's blood between these two syringes. So 9 ml saline, 1 ml air, few drops of patient's blood. Shake for about 18 times and then inject into the antecubital vein. After about 6 seconds, ask the person to blow into this one, which is like Valsalva. You don't need this instrument nowadays. You can just do a simple Valsalva. What you're going to see in this video is when we inject, this right atrium becomes white in color because air bubbles are coming here. And then you are monitoring the brain and you are looking for it here. Just concentrate on this video. So this is what we are shaking. The sound which you are hearing, this is from transcranial Doppler. This is where you are injecting the solution, saline plus air. It becomes white in color. Then the person is doing Valsalva, just about 30 millimeters mercury. And what you start seeing is, just look for these sounds. Just look for these sounds. These are the air emboli which are reaching the brain. These are the air emboli seen in the left ventricle. There is no way, if you don't have a communication with interatrial septum, that you are going to see any emboli, because we are injecting into a vein and the emboli are appearing on the arterial side. So that means this patient is having a right to left shunt. She had a history of travel. You know where was the problem. She had a DVT during the air travel. And that DVT, the thrombus moved up. Thrombus reached the right atrium. And she did some kind of Valsalva like lifting weight, bending forward, coughing, sneezing. This all increases the pressure on the right atrium. These emboli, they go into the left side. They go to the left ventricle. And we know it that 20% of our cardiac output goes into the brain. When they reach the brain, they create the problems. So the story can be completed very, very easily. The problem is that we know that the gold standard is TEE. The problem with TEE, although we can do it, we do it mostly as outpatient basis, but it's very poorly tolerated. We need to give a little bit of short sedation to the patient. And when we put the endoscope into the throat, these patients are unable to do Valsalva. So the test is not very comfortable. And the test, but it's important because you need to see where is the shunt. The test is done like in the office like this. So this is not a cigarette in patient's mouth. This is a spirometer which is going to blow into. So we know it was adequate Valsalva. Patient is sitting in the clinic. This is the plug which we are shaking. And this is the TCD frame. Everything is being done in the office. You don't need to take this patient to the hospital. The test takes total of only 26 seconds. It's not something you need few hours to do the test. Once you have set the plug, once you have prepared solution, monitor for 22 seconds only after injecting, and that's it. and then you know the entire diagnosis for the patient. The beauty of TCD is you can change patient's position, which you cannot do when you are doing TEE. If you do TEE for this patient in supine position, it's a very small shunt. Every white line is a bubble going into the brain. But when you do the same test in sitting and leaning to the right side or sitting straight, the number of bubbles become almost like 10 to 15 times. So this is what the office practice helps, that you do the test, which you can do easily. It's the cheapest possible test. Saline is free in the hospital. Air, we don't have to pay for the air unless the government puts air tax on us. So blood is patient's own blood. No risk, no side effects reported with this patient. And in 22 seconds, you know the entire diagnosis for your patient. It resolves why she was having migraine. It resolves why she was having migraine with visual aura. And it tells you why this patient was having recurrent episodes of TIAs. The TCD in your office permits you to say, is it a high-risk TIA or it's a low-risk TIA? Is it a high-risk shunt or low-risk shunt? Because we can count the number of bubbles going into the brain. Once they cross 31 in total of 22 seconds, you know this is a high-grade shunt. This is a shunt which needs more care for the patient. And this is how it looks like. Just look at the echo, how it looks like in the echo. Same thing, this is right atrium and this is the right ventricle and this is the left ventricle. Look at, this is the injection here, and you see how the bubbles are seen in the left atrium and the left ventricle. But this is possible only on TEE. Looks very beautiful image, shows very clearly that there's a shunt here in the interatrial septum, which is a PFO, very easy to treat. To bring the patient, outpatient appointment, come to the echo lab, we just put this Watchman device and everything is closed. This person will be free of these events for the rest of life. This patient does not require any antiplatelet treatment after 6 months of treatment once it's completely closed, and you have resolved the whole problem for this patient. This is how it is put up. If you are looking for the guidelines, yes, there are very strong guidelines. We came out with these guidelines just a couple of years ago for the Asia Pacific, but they are valid for the entire world. This was out of a consensus conference that we came out who should be closing or who should not be closing. This is the paper, very interesting to read because we created a road traffic sign that if it is a red color, don't go. If it's a green color, go ahead. If it's an orange color, think twice, re-evaluate patient, and then you close it. But always find out that there's no other source of embolization for this patient. What about seeing a patient with carotid stenosis? These are difficult patients because they keep getting events and you are puzzled what to do for these patients. Now, this is the carotid duplex for this patient. Again, office. You see, there's a very severe stenosis of one of the internal carotid arteries. This is like more than 70% stenosis. And it's a very soft plaque. Now, again, coming back to same question, the mechanism. Is it artery-to-artery embolization? Is it hypoperfusion? Or is it both are equal players? For embolization, again, it's a very simple test, 40 minutes test. Put the head frame, you keep doing your work, you don't need to sit with the patient. Keep doing your work. If the embolus comes, it will call you that, yes, I have appeared here. Because it's a very loud sound, like a bird chirping, that kind of sound will come. So you can hear this sound and just wait for this sound. This sound says that emboli are coming out from the carotid plaque and probably they are responsible for these persons' episodes. What about hypoperfusion? Again, a very simple test. This test takes about 45 seconds only. So I'm a very impatient person, cannot wait for 2 days for the report. I want the things to be done within minutes in my office. Put the head frame, monitor the 2 MCAs, ask the person to hold breath. Very simple. Hold breath for 30 seconds. If he cannot hold breath, put a paper bag, which is a standardized paper bag on nose and mouth. Let him breathe in and out of this bag. It will increase carbon dioxide and see what happens to the flow velocities. So look at the trend. On the right side, the velocity did not increase at all. On the left, it has increased significantly. That shows that this person is in problem. Monitor it. If you monitor for a total of, if you are doing the test with breath holding, 30 seconds is enough. If you are doing with a paper bag, 45 seconds. And what we are looking at vasomotor reactivity. We are testing autoregulation. Whether this person can increase the blood flow whenever there's a demand by the brain or he's unable to do it. And what you're looking at is when we hold the breath for 30 seconds, we increase carbon dioxide by nearly 3 to 4 millimeters mercury. Every millimeter mercury change will increase the flow velocity by 10% or more. If it does not increase, then there's a problem. This is a 40-second record for this patient. You see it. This is normal response on the left side. The velocity keep increasing as we hold breath. On the other side, there's a paradoxical reduction. It is dropping rather than increasing. So that means this person cannot increase. You can do a fancy imaging like this is an acetazolamide challenge SPECT. You can see how much of the brain is at risk once you challenge. It's a acetazolamide, same thing, you are increasing carbon dioxide in the brain. Except now, instead of doing a vascular imaging in your office, you have to send the patient to do the scan on 2 days with 99 technetium HMPO. So that's a baseline scan, which looks almost equal per metabolic perfusion on 2 hemispheres. Here you see a huge vasodilated deficit. That means there are 2 problems with this patient. Number 1, he is throwing emboli. 2, he is having a less blood flow. So your aim is actually both ways. You need to reduce emboli and you need to improve blood flow. We can reduce the emboli by using antithrombotic therapy. It's very easy. Once you start double antiplatelet therapy, once you add a statin to this patient, this emboli will disappear in 2 or 3 days. But you cannot improve the perfusion. There is no technique to improve perfusion except aggressive hydration or admitting the patient. What we cannot do, the only solution is operate this patient whenever you have time. So I showed you a couple of cases of cerebral ischemia, but there are few interesting things. I'm not going to talk about movement disorders, but I'm going to show you a couple of interesting cases. This is a 22-year-old girl, and she was brought to the to see. Multiple doctors saw her, and the complaint was every time she will go into the exam, she will have a right hand shaking, and every time it happens only in the examination hall, and she will come out from the examination hall. She was a very bright student. She was the topper of her class, but this is what started happening to her. Go to exam, hand starts shaking. When she was brought, neurology exams were normal. Somebody did a CT scan, which was normal. Everybody said initially that this is functional. She is anxious. She must not have prepared well for the exam, and she was worried, and this is why it happened to her. But somebody did an EEG for her that it may be an epilepsy. And what it shows was there was a left frontotemporal region slowing. When we read EEG for adults, it just says that fine, there's a structural lesion somewhere. Our CT scan was normal, but remember, CT scan is not a very good thing. But when we were doing the EEG, we usually do hyperventilation. She had the same hand shaking episode. And when we asked her, is it the same way how your hand shakes? She said, yes. But EEG did not show any ictal runs. So there was no correlate on the EEG. The EEG was just showing slowing only. But this prompted us to do the MRI. But I'm showing you what the tremors look like. Those people who do epilepsy, I want their impression that what do you think about this? She is talking. This is you are hearing she's talking. She is fully conscious. She is holding her hand from the other side. She tries to limit the movements of this hand shaking. And this is what was happening to her. So those people who do epilepsy, they will say, there was no rhythmicity, there was no spread. So it does not sound like this was an epileptic thing, but there is always a doubt, that there is something which is going wrong with her. The MRI was done. MRI did not show any structural lesion. What MRI showed was there is a cutoff of the left middle cerebral artery. There was no MCA on this patient, no MCA flow. It's a near complete occlusion. And this is what we picked up on TCD. We did the vasomotor activity, was exhausted on the left MCA. It did not increase at all, rather it dropped. And when we did the hyperventilation, it is hypercapnic, that means breath holding, same thing happened with her. So we had this person shaking of the hands in exam. She was having hand shaking when she was doing hyperventilation during EEG. And she was having same hand shaking when she was doing a breath holding. So that means her brain is unable to take any challenge. This is what we did for her, the SPECT. It showed very clearly that this is what happens to her when she goes into any of the challenges. And during the Diamox challenge, again, she had the same episode, which was a little bit more prolonged. But by that time, we knew what was going wrong with her. The question is what to do for her. So this was published in Annals of Neurology as a involuntary handshaking, what do we call it? Is it transient ischemic attack? Is it a seizure? It is psychogenic. TIAs or stroke, they are mostly negative phenomena. You lose power, you lose power, speaking ability, you lose your vision, you lose sensations. This is stroke, which is always a negative thing. This was a positive phenomena. Handshaking is a positive phenomena. There was no weakness at all. So positive phenomena, the classical teaching is they are never cerebrovascular diseases. Handshaking, leg shaking are described, but leg shaking is of different type. I have seen a lot of leg shaking TIAs, but handshaking, this was first experience for me to see in every position. We did this bypass surgery for this patient, which is a very simple surgery done outside the head, outside the brain. It's a very fast surgery, no mutilating figures on the head, no scars visible after 6 weeks because hair grow back, and everything is back to normal after that. I have been seeing this patient for last 10 years. She has been perfectly well. She is one of the top achievers in the company where she is working. She keeps coming to see me almost on a yearly basis, except for COVID, she did not come. And she is only on aspirin tablet. We repeated SPECT for her. This was totally reversal of the reverse Robin Hood syndrome, which we were seeing. And she has been well for last 10 years. We are very happy with her progress. Being a neurologist, I also see neuromuscular disorders. Sometimes they come, sometimes they are challenging. So this is one 27-year-old girl. She came with a history of droopy eyelids, and which was worse in the afternoon. For neurologists, this is a cakewalk. Just the first sentence says she's having myasthenia gravis. She's a female. There's a droopy eyelid, which becomes worse in the afternoon when she's tired. You don't need anything else. There was no diplopia, no weakness, numbness, fatigability. She did not describe anything. Purely ocular symptoms. Her pupils were round, equal, reactive to light and accommodation. Everything was fine. I'm just showing it how vigilant you need to be in the clinic. This was her photograph. You can see there's a left eye ptosis. Very easy. Very easy diagnosis. You don't need to do even hydrophonium test for her. Probably you can start treating her and just explore that there's no thymoma. This is a video for this patient, and this clinches the diagnosis. That means you don't need to do any investigations for her. There are multiple findings here. And I'm going to show you these findings. You just keep looking for, neurologists are taught about one sign called Coggan's twitch. You will see Coggan's twitch in this patient's eyes. And then you will see a very peculiar phenomena, which is called a seesaw ptosis. The question here is she having ptosis on the left eye, or is she having ptosis on the right also? That's a big question mark. On just this picture frame, it looks like ptosis is only on the left. Myasthenia, remember, is a generalized disease. If I prove that this is generalized and bilateral, I don't need to investigate this patient further. Just look at the video. Keep looking at the left eye. We are not doing anything. She's just looking. Then I lift this patient's eye. You see the right eye. What happens to the right eye? Just see. There was a Coggan's twitch. Now you see this patient like this. I lift the left eye. See, the right eye goes down. This is called a seesaw ptosis. That one eye, we lift it up, other eye goes down. That means she is having ptosis basically on both sides. But the clinical examination looks like it's only one side. And when you see one-sided ptosis, you always start bringing differential diagnosis into the picture. In this case, once you lift this eye, the brain's input goes away, and then the other eye starts drooping down, because we lift both eyes together and bring them down. Only dancers can lift one eyebrow at a time, those who practice hard. Otherwise, most of us, we move both eyebrows equally and together. Keep looking at it again. It's a very interesting video. And I'll show you how interesting this video was. That I sent this video to New England Journal of Medicine. This is the highest impact factor journal. And within 5 days, they sent that we accept this. We are going to publish it as a video. It was published in New England Journal of Medicine. We did not do any further investigations for her. We just treated her. She did not have thymoma. She has remained well for last couple of years. So I will try to end here unless there are a few minutes with me. Hardik, are there any?
Sir, thank you. I mean, we will have to conclude here.
Yeah, okay. So what I want to say is that You just need a very good clinical history, and you need to keep eyes open when the patient enters into your chamber, because this is the best thing for neurologists. Just try to understand the mechanism, why this thing is happening. Once you know the mechanism, that's the easiest way. And I always say that I do a lot of TCDs. This is a powerful tool. It empowers you to become a better neurologist, especially when you're dealing with conditions which have any alteration or disturbance in cerebral blood flow. And I will stop here. Thank you.
Thank you, sir. Always a pleasure to hear you. I think very quickly you have taken us through varied cases presenting as, stroke mimics, chameleons, what can we say? Very interesting, especially the last case. It was very enriching to a neurologist's mind. Thank you very much for sharing this. And we hope to learn a lot from you in the future. So we are now moving from the topic of cerebral ischemia and the keynote towards pediatric epilepsies. And for that, we have a very eminent speaker from Mexico, Dr. Alejandro Ayaviri. So I welcome Dr. Ayaviri for his presentation on pediatric epilepsy presentations. Over to you, sir.
Thank you very much, Dr. Hardik. Hi, just making sure you can see my screen now.
Yes, sir.
Great. Just let me just do this. Okay. I have a few videos. Okay. So thank you very much again for the invitation. It is my pleasure to be speaking today with you about the outpatient management of pediatric epilepsies in this third Neurospace symposium. So we are going to talk today about epilepsy. And historically, epilepsy has received many names. It has been called the sacred disease, and it is one of the oldest known diseases for mankind. The first reports on epilepsy can actually be traced back to the Assyrian text almost 2,000 years before Christ. This is actually a very nice cuneiform tablet that was found and was a study. And what they found there, it was that there was this image in the lower part that when looking closer at this turned out to be a demon with horns, tail, and snake tongues that, according to the text, was the cause of this dreaded disease, epilepsy. So these are the first origins of this disease. Epilepsy also has regaled and has fascinated artists over centuries. And their fascination has been expressed in various different types of arts. I would just like to take you to this central imaging. Some of you may recognize this person. This is Valentine of Terni, and as many of you know, Valentine's Day is celebrated on February the 14th. Everyone who is a romantic would know about this. But a lesser known fact is that also Valentine of Terni is the patron saint of epilepsy. There are also many famous people that have lived or that currently live with epilepsy, and you can just see a few examples of this person here in this slide. So also, when talking about the outpatient clinic, it is important to remember that epilepsy is actually one of the most commonly seen diseases. You can see this slide. There are two different studies here. The study on the right is a study made in Sudan by Dr. Mohamed, and the study in the right side that is in Spanish, it's a study that was made in Mexico many years ago. But as you can see in both hospitalized patients or ambulatory patients, the percentage of epilepsy or seizures, as they mentioned here, it's the highest among the different hospitals. Also, in the study in Sudan, you can see here that seizure disorders were the most prevalent disease that they see in their outpatient clinic. So, well, everyone who is familiarized with neurology would know that probably every 3 out of 5 patients that come to your clinic will have some kind of epileptic disorder, or at least a suspicion of one. I want to show you, these are 2 very important papers. I would definitely encourage you to review if you have not done so already. Both of them are published by the ILAE, the International League Against Epilepsy, in the years 2014 and 2017. And they give you the current conception, the current concept of what's the definition of epilepsy, what's the definition of seizures, and what are the different kind of seizures that you can sometimes encounter. So we will just briefly go over these basic concepts. So this is the conceptual definition of seizure and epilepsy, which was done in the year 2005. And they define here an epileptic seizure as a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Whereas epilepsy is the disorder of the brain that's characterized by the predisposition to generate epileptic seizures and requires to have the presence of at least one epileptic seizure. There is also a more practical or more operational clinical definition of epilepsy, in which you can have a patient diagnosed as epileptic by one of the following conditions. You can have a patient diagnosed with epilepsy. This patient has had 2 different unprovoked seizures that are separated more than 24 hours apart from each other. You can also have one seizure, one provoked seizure, and a probability of developing further seizures over time that is high, and defining high at least as 60%. Or you can also have the diagnosis of an epileptic syndrome. So just to wrap this up, let's do some of the numbers that we see in epilepsy. So one basic concept that doctors who manage epilepsy have to take in mind is that while all patients with epilepsy will experience seizures, not all individuals with seizures will have epilepsy. So taking this into account, unprovoked seizures, meaning seizures that don't have a known trigger, will be pretty frequent. They will be present in around 8 to 10% of the general population by the age of 80. And there is a risk of recurrence for these seizures. You can speak about 1 year risk of recurrence of about 36, 37%. You can speak of 2 years seizure recurrence risk of around 4 to 5%. And if this person presents a second seizure, the risk of him having a third seizure goes up to 73% and 76% for a fourth seizure. So you can now understand why you can define the epilepsy as having one seizure and a high risk. Now this risk that is above 60, because that is pretty much the same risk that you would have after a second seizure. And also the number of this will be the person that will definitely be diagnosed or eventually diagnosed with epilepsy. So there is this really nice study that has defined the full incidence of rate of epilepsy to be at 61.4 per 1,000 person years. Okay, so that was just like basic concepts that we needed to understand before going into what drives our attention today. So this is and this is actually a picture of the hospital I studied my residency in, and you can see here this is the entrance to the outpatient clinic, and this is how they were seeing patients there during the pandemic. So we are now going to speak about these patients that come to the clinic, and there are 3 questions that one must ask when approaching a patient that comes to you for a possible epileptic seizure. So the first thing you want to know is this really a seizure? The movements that this baby is having, are they really seizures? Is this really something that has an epileptic origin? Second, if this is indeed a seizure, what is the risk of recurrence? Does she have epilepsy? Does this patient have epilepsy? And finally, you want to address if do I need to start treatment. So let's talk about these subjects for a moment. So first things first, is it really a seizure? It is very important to know that misdiagnosis of epilepsy is common, especially when talking about children. Misdiagnosis rates of epilepsy goes between 2 to 71%, and this leads to almost 30% of patients receiving unnecessary anti-epileptic medications. There is this perception between clinicians that missing the diagnosis of epilepsy and not treating the seizures is riskier than erring on the side of caution. And they decide to treat despite having sufficient clinical information and the risk of exposure to unnecessary anti-epileptic drugs. It is always important to consider differential diagnosis, especially in younger children, and also when taking into account the use of ancillary or auxiliary tests, the overinterpretation, the false positives are common. It's very important to be aware of what are normal variants, both in EEG and in MRI. So I want to show you this quote here. This means hardly anyone with epilepsy will come to any harm from a delay in diagnosis, whereas a false positive diagnosis could be gravely damaging. So that this is very important. Okay, this is very important to know also that there is class 2 evidence that treatment with anti-epileptic medication after a first seizure, as opposed to wait for a second seizure, does not show to improve prognosis for long-term seizure remission. So it is sometimes better to wait and be sure that the patient really does have epilepsy than to treat like very promptly. So as I was mentioning, there are a lot of differential diagnosis for these. There are a lot of non-epileptic paroxysmal disorders that can be sometimes mistaken as epilepsy. We will of course not see all of these now, but we will see some of them that I have found more commonly in my practice. So the first one, I am going to show you some videos here. These videos are presented with the permission of the families. They are not authorized public distribution, so I would encourage you not to record them, but I will show you now. And so this is one of the most commonly seen scenarios in the outpatient. So there are these babies that sometimes can present with these movements that usually they will be bilateral, they will be repetitive. This will be a baby between 0 to 3 months, and they will occur only during sleep. They will settle, they will stop when the baby awakes, and they will be present in the baby that is otherwise healthy. Sometimes or many times you will want to do an EEG on these patients, or actually a video EEG, just to make sure you don't have any epileptic activity correlating with these events. And then, well, you can definitely diagnose this as benign sleep myoclonus. Another one that we see in practice is this one. You can see here, these are called shuddering attacks. These are older babies. They will be between 4 to 6 months. They will involve the head, the trunk, the shoulders. They will usually be really fast. They will last 1 to 2 seconds. They will present many times a day, and they will usually have a trigger. Could be eating, could be drinking, could be nursing, some kind of a stimulus that will give you these sort of events that can sometimes be frightening to the parents, and uh, they can suspect these to be seizures. So it is very important to be aware that there are these events that could be suspected as seizures, but many of them will not be that. And then there are also the type of seizures that you do not want to miss. And we have to talk here about a concept that's the concept of epileptic encephalopathy. So epileptic encephalopathy is this group of epileptic disorders in which the epileptic activity itself impairs cognitive and behavioral function above and beyond what would be expected from the pathology underlying alone. So this is very important because prognosis for this is generally quite poor, but there is a minority of cases. There are some cases that can be ameliorated, can even be cured with prompt diagnosis and successful treatment. The most important of these kind of seizures is the one you're going to see here. So this is a 6-month-old baby. She has these sudden simultaneous movements that are typically referred to as arms up, head down. They will occur every few seconds in clusters all around the day. The EEG for this baby is very important to be done very quickly, and it will have a very chaotic EEG. She will have a very, how we say this, like very epileptic EEG, which will be called hypsorhythmic, and this is typical of the West syndrome, the infantile spasms. And this is something that if we continue to leaving the epileptic activity go on, then there will be a lot more damage than if we treat this very promptly. So we want to see this. There is another type of seizure that I want to address your attention to. These are called atonic seizures or drop attacks. The muscles suddenly relax, they become floppy. If the baby would be standing up, he would often fall, usually forward, and may even injure his front or his face, you know. And like tonic seizure, these tend to be brief and happen without warning. These type of seizures are commonly seen in some epileptic encephalopathies and should always cut our attention to act more quickly. Okay, so now that we have defined already that this is indeed a seizure, we have to try and find out what's the risk of this seizure recurrence. And this is a very nice study. This is a study that was made by the MES group. This is the multi-center trial for early epilepsy and single seizures. And what they did here, they give one starting value, depending how many seizures the patient has had at the moment of the processation. He could have one seizure, 2 or 3, or 4 or more seizures. And then we would add one more point if the patient has a neurological disorder, learning disability, developmental delay, or if he has an abnormal EEG. And then we would classify these being at low risk, medium risk, or high risk. And the idea here is that we can classify this and give us an idea of how much would this patient have a percentage of recurrence risk of seizure. So we can have these patients in the low risk when they will have just one seizure and everything else is normal. He doesn't have an abnormal EEG. He doesn't have a neurological disorder. Physical exploration is perfectly normal. And then we would see that this patient would have an epilepsy risk or a recurrence risk at 1 year of 19%, at 3 years of 28%, and at 5 years of 30%. Then we would have the second group, that is a group of medium risk, where we would have 2 or 3 seizures at presentation, or 1 seizure plus neurological disorder, learning disability, developmental delay, or abnormal EEG. And this patient would have a risk of recurrence of 35 at 1 year, 50% at 3 years, and 56% at 5 years. So he would be closer to that 60% that we would need to treat very promptly. And then you have this high risk. These are patients that start with 4 or more seizures, or they would have this seizure plus neurological disorder plus an abnormal EEG, or they will have 2 to 3 seizures and an abnormal EEG, and then the risk is higher. You know, the risk of recurrence at 1 year is 59, at 3 years is 67, at 5 years is 73. So this is very nice to know, and this is very nice because it gives you an idea, but you would have to be like very, very alert of this in the outpatient clinic. So there is one thing that came to do our lives easier, and is this. This is a very nice thing that was done by the group of the Van Diesen doctor, and they did this prediction model to determine childhood epilepsy after one or more paroxysmal events. So you can just like you can scan this QR, you can go to this web page, and it will take you to this page. I will just show you briefly again this. What you want to do here is you want to scroll down. You want to scroll down until to where it says first consultation. It's right here. You just go there, you put go, and then you just have to fill in the fields. You just have to put the sex, the age of the first seizure. There are 5 event description items. There will be bilateral shaking, tonic posture, lateralization of symptom, weakness or automatisms. There are also 2 items that refer to previous history, especially about neurological previous history or history of a psychiatric disorder, and if there is a known genetic or metabolic syndrome, and what's the EEG result. Then you can just place lookup, and it will give you a probability of epilepsy in a number, and you can sometimes use this in your clinic to take some medical decision. There are some other prediction tools in this same page that you can definitely check out if you want. So now that we have seen that this patient does have or doesn't have a risk for recurrence of the seizure, so now we start talking about medication. So it is very important to know that anti-epileptic therapy leads to seizure freedom in about 70% of children with epilepsy. And actually, the lack of response to the initial appropriately selected anti-epileptic drugs could predict a poor response to other drugs. And therefore, choosing the initial anti-epileptic is of paramount importance. And you would have to take into account the seizure type, the efficacy of the drug for that seizure type, and what's the side effect profile. Fortunately enough, in epilepsy, unlike with our infectious disease colleagues, we do have a lot of choices. And the last years have been of rapidly developing of new drugs for treating epilepsy. So this was published in the year 2011 by Brody. At that time, we had 20 anti-epileptics. Today, we have 25. And this gives us a lot of possibility to use them. So I will just give you some brief pearls of this treatment and just mention that you sometimes, if you are not completely familiarized with epilepsy, you may want to start with the broad spectrum anti-epileptic. This will be useful in both focal or generalized seizures. And there are 2 choices for this. Which are levetiracetam or valproic acid, could sometimes be presented in different countries with different names, such as sodium valproate, magnesium valproate, as we have in Mexico, semi-selective valproate. But the thing is that they will all have this valproic molecule. It is also important to know that for generalized non-motor seizure absences or for myoclonic seizures, you want to avoid these anti-epilepsies that could act over sodium channels. Same can be said for certain syndromes such as Dravet, and you don't want to use carbamazepine, oxcarbazepine, or phenytoin in those syndromes. Finally, you want to take into account the pregnant or fertile woman. You want to avoid teratogenic anti-epileptic drugs such as valproic acid or carbamazepine, and prefer lamotrigine. And there are some special considerations in children that need to be addressed. And I just want to tell you that there are these epilepsies that will have a benign natural history in children, and they will be self-limited. So starting anti-epileptic drugs may not always be the choice. You have to consider cognitive behavioral side effects of anti-epileptic drugs and try to avoid them as possible. This is true for phenobarbital, for most of benzodiazepines. It is very important to know, and it's very, very interesting. Young children don't drive. And this is very important in adult patients. Many times after their first seizure, the decision of the patient to start on medication is because he wants to start driving again. So young children don't do that. And therefore, it is very rare that an anti-epileptic drug is started after the first seizure. You many times want to wait there. And also, nowadays, there are these precision medicine opportunities based on a specific genetic diagnosis. You know, we are more and more doing genetic diagnosis, and therefore, we now have some special treatments such as stiripentol for fenfluramine for Dravet, pyridoxine, quinidine for KC, NT1 epilepsies, and other. And finally, one last thing that I wanna mention to you is that discontinuation of therapy in children could be more quickly done than in our population. So before thinking of withdrawing anti-epileptic drugs, a minimum of 2 year seizure-free period is recommended. And you will have three groups of patients in this case. You'll have this group one, which will be the benign seizures. 15 to 20% of all children will have these. And these are children that after 2 years, you can start withdrawing medication. There is this group two of very high risk of seizure recurrence. This will be the patients that have like metabolic diseases or have brain malformations. And then you will think that these patients will be really hard to withdraw medications, but you can sometimes try to let them with the fewer anti-epileptic drugs that they need. And the biggest group is the group of uncertainty. So these are 70% of all children. And for them, you definitely want to take into account some of the factors that may give you a further risk of recurrence after withdrawing medications, such as the presence of epileptic abnormalities on EEGs, the onset of the epilepsy before 2 years or after 10 years, the intellectual disability defined by an IQ less than 70, or the history of status epilepticus and higher seizure burden. There is also one very nice study that was done, and it's actually published in Ukraine, that compare weaning over 9 months versus 6 weeks. And there is this, and there is no significant difference in seizure recurrence risk when doing a more quickly 6 weeks withdrawal of the medication. So I think that that's my last slide, and thank you very much for your attention and for the invitation to speak with you.
Thank you. Thank you very much, Dr. Ayaviri. Your presentation has showcased some very interesting pearls, particularly on medical management of epilepsy. And I think very useful would be the prediction model which you have shared with the group. So thank you very much. I will now request you to stop sharing your screen. And we will come back to you with some questions on this topic, which we have already received. And for the audience, we will revisit the topic of epilepsy in a very interesting case presentation later. But for now, we move to the topic of headaches. And we have none other than our chairperson talking about headaches today. And I welcome Dr. Arvind Sharma for his presentation.
Thank you, Hardik. Thank you very much. I hope you are able to see my slides.
Yes, sir.
Thank you. So first of all, I will thank all the speakers to come on this platform, and especially our keynote speaker, who's always part of this program, right from the inception, Dr. Vijay Kumar Sharma. So we are able to incept this program. And a wonderful talk by Dr. Vijay and Dr. Alessandro, beautifully mentioned about the pediatric epilepsy, and it was really a great learning. So now moving to the next topic, as I know, we have 3 hours and 4 more talks to be there, and I tried to finish it another 15 to 16 minutes. And the topic, you know, that today, even if I did my OPD for 30 patients or 26 patients, out of them, I think 40% or 36%, if you are practicing your general neurology, where you have this symptom, what is known as headache. And as we are sitting in this group, I can ask everyone, those who are attending, they can also say that how many. I think there will be very less who never have a single episode of headache in their life. So it is a very important symptom which is there to identify what is the headache, right? And what are the different types of headache, and what is the important to treat certain headaches. And the most important for any neurologist, all will agree, all speakers here agree, most important for the neurologist here is to differentiate from the primary headaches to the secondary headaches. The secondary headaches, which are very grave and the prognosis is very bad, you have to identify them fast. The red flags has to be known. So we'll discuss about some of the major type of the headaches in the neurological practice. Patient coming to you with non-specific headache because of the, there is a, we laugh in our clinic like headache because of the spouse. Don't call it wife or husband, right? Differentiating between the migraine and other primary headaches. The case 2 will discuss about the migraine mimics, and which is very important. We see a lot of mimics when you see in the outpatient clinic. Burden of the migraine, as you know, how much migraine is underdiagnosed, and WHO has made it equivalent to dementia or quadriparesis, because you see from the last, from the president of the United States or across who are holding a position, the major absentees to the hospital is to the hospital or any place, administrative place or anywhere where they are working, is because of headache. So it can be migraine on an outpatient therapy for migraine. This is my outline for my presentation. So there will be the first case, which I'm going to, the 54-year-old female with 3 years of history of headache, initial 2 days per week, but almost daily now. Left side stabbing, pressure tightening for 2 to 3 hours during the attack. And the headache scale, if you see from out of 10, it is 8. Pain is localized in the left posterior neck behind the left eye. And as they are very frequent, if it is a single one-time headache with the neck pain, you will think about the dissection, right? And with some focal deficit, nausea and vomiting 5% of the times, light and noise sensitivity, intermittent blurring vision, these all history. You know, headache diagnosis is all on history. History is very important. When you see the history, you have to certain points which has to be there. Tearing of the left eye, redness during intense pain along with the nasal congestion. Often feel restless during the attack. So the question to the audience is, what is the type of headache this patient in case 1 is suffering from? So should I wait for 10 seconds?
Yes, sir.
Okay. So our IT boss will let us know, right? The answers.
Yeah. So we can wait for 10 seconds and then you can proceed. We can discuss the results later.
Later. Okay. So you can give me the heads up. I'll move to the next slide. So is it a migraine, tension type headache, and cluster headache? We know tension type of headache is the most common headache in our clinical scenario. Should I move further, Hardik?
Yes, sir, please.
Yeah. So whatever you have answered, but you should know that headache lifetime prevalence for anyone is 96%, 3 times more common in females. It is more common between 25 to 55. We all know migraine has a bimodal peak. It is once start at the age of 8 years for the boys and at the minority for the girls. And with the age, that is the only disease, if you control with the lifestyle modification, I'll call it as a lifestyle disease. If you control it, headaches are controlled. Active prevalence in the general population, migraine is 10 to 12, 15%. And I told tension type headache, which is like the weight is put on the head, is 40%. Trigeminal encephalgia or cluster headache, that is the TAC, is 0.1%. So this is the various areas where you can put the headaches. If you see on this slide, on the pictures, the ice cream headache are all in the central, if you can see my arrow. Sinusitis, you know, on the frontal, ethmoid, and the maxillary. And this is what the migraine is. Cluster, as you've seen, the red eye, it is on behind the eye, somebody is stabbing. There is some nasal stuffiness at that time. It has the periodicity, you know that, and restlessness is very common. Tension type headache, some has put on weight, and neuralgias, you know how they are. So why headaches? So there are some sensitive structures in the brain or insensitive structures. All extracranial structures, skin, venous sinuses, major arteries, larger branches, most of the dura and dural arteries and the periosteum are pain sensitive. Insensitive, the brain parenchyma is insensitive, most of the meninges other than dura. So there is a dural inflammation. dural stretching whenever there is a surgery done, when the meninges are affected, the dura, if it is affected, the pains. The pathophysiology for different headache is different. Like for migraine, it is totally the inflammatory markers. Then the tension, the vascular origin, location does not correlate well with the location of the pathologies. It can be a counter coup kind of things. The headache start from the occipital. The headache results from distension, inflammation, tension, and traction of the pain-sensitive areas, which we have discussed all about. So if you see differential presentation for the headache as we're discussing, the chronic tension type of headache in this comparative for all the headaches is 60%. And if you see the migraine without aura and they are following the next, and even the medicine overuse headache, it is very underdiagnosed. We have to ask that history, that how many medication the patient is taking for the headaches. Nitrates are there or not. There are various drugs which cause headaches and they are typical in nature. So tension type headaches are the most common. Migraine headaches present classical with or without, and cluster headaches are less common. So if you see all the three presentations simultaneously, we discuss about the 4 points like pain, headache duration, associate symptoms, and behavior during. So if you see pain, it can be for migraine and unilateral or bilateral. It is not always half like this and aggravated by the routine activity, but tension type of headache, it is band-like, dull. People love to talk at that time, mild to moderate. And cluster headache is unilateral, stabbing in the eye, severe. Duration 4 to 72 hours to days for tension. And for cluster, they are of shorter duration, 15 to 180 minutes. Associated symptoms for migraine, photo or phonophobia, it is not necessary always. Nausea and vomiting. Associated symptoms for tension, occasionally photophobia or phonophobia. But for cluster, it is unilateral lacrimization, nasal congestion, even the ptosis. And other like sunt, and they are also having the congestion of the eye. Behavior, they want to lay in dark and quiet room. You all know about migraine, and able to even prefer to stay active in tension. They want to talk about their problems. Cluster headache, they're restless and very agitated. So if you see what are the episodic, less than 15 headaches per day per month are episodic, but if they are greater than 15 days per month, they are chronic. And if you see the medicine overdose, if they're more than greater than 15 days per month with any simple analgesic like paracetamol or naproxen, and 10 days more for triptans, ergotamine, even the ergotamines like Vasogren is used a lot, cause of dull background headache. And if it is greater than equal to 3 months, that is the medicine overuse headache. Migraine have aura, sensitivity to light, but for tension, it is bilateral, does not affect daily activities. Cluster, the main point to remember, shorter duration, cranial autonomic symptoms. So the first case of ours was a cluster headache. Whosoever got right, congratulations. Those who haven't, this is the important slide to tell you about the cranial autonomic symptoms like red eye, tearing, ptosis, lid edema, nasal congestion, rhinorrhea, which is typical of all the TAC phenomena. That is the trigeminal cephalgias, that is the trigeminal autonomic reflexes. And they are of shorter duration in comparison to the migraine headache. And restlessness is the characteristic of such cluster headache. Now coming to the red flags, it is very important to differentiate the primary headaches from the secondary headaches, like new headache in older patients, abnormal neurological examination like papilledema in benign intracranial hypertension, which is the closest mimic for the migraine, and change in the mental status, new changes in headache pattern and progressive headache, new headache in a setting of any infection, cancer, or immunocompromised state, systemic illnesses, triggered by cough, exertion, headache in the pregnancy, the corticovenous sinus thrombosis, having a typical triad of fever, headache, and seizure, and first or the worst headache like a thunderclap headache. So the case 2, that is the 56-year-old man referred to as specialty care for the community clinic, worst headache of his life. Patient has similar episode 3 days ago. Both headache described as acute, maximum intensity at onset, worst headache of his life, and pain intensity reached maximum 10 to 20 seconds. CT angio negative for aneurysm, thrombus, and vasoconstriction. So what would be the next course take for the case 2? It can be a scan like MRI or CT, bedside TCD, or none of the above or both of the above. I will take only 5 to 10 seconds for this. And a C and D I have not mentioned here. You can do even C and D for this. So it depends on how you answer that. If you answer both, it is totally okay. How you answer, let me see. Hardik, can I move further?
Yes, sir.
Yeah. So the classic thunderclap headache, there are the secondary causes which are very important for residents who are attending this and the young neurologists. The RCVS, the reversible cerebral vasoconstriction syndrome is most important. Than the non-aneurysmal SAH. They are the spontaneous SAH or the post-traumatic. They are very important. Venous sinus thrombosis, pituitary apoplexy, vascular dissection, spontaneous intracranial hypotension and hypertensive crisis, which are very important for the thunderclap headache, and they are very important DD for such. You can see a subarachnoid hemorrhage in this case on MRI, along with the posterior occipital convexity, small focus of enhancements in the left parieto-occipital region here. And TCD, you can see the higher velocities in the MCA and the elevated Lindergarten indices. So coming to the migraine mimics and the chameleons, the most important mimic for the migraine, whenever patient come to the recurrent headaches, not responding to your acute medications, even the triptans or the analgesic, and not responding to your prophylactic, I would say definitely go for a scan and look for benign intracranial hypertension. Even you have to do a lumbar puncture for such cases to see the increased pressure. It is very important. Cluster headache, we know that. SAH, we have told about. Occipital epilepsy, which has visual error, may confuse this with a migraine attack. So it is less than 2 minutes, which is very important. And vertiginous migraine, a lot of vertigo patients, they are being treated in a different manner, but we take a history about headache in the background. So even the heaviness of headache, sometimes there is a change of character in headache when they are having a typical migraine attack before, and subsequently the migraine is transformed. Now they don't have headaches, they only have a vertiginous feeling. That is the imbalance. They are not the subjective and objective type of vertigo there, that they feel revolving of self or the revolving of the surrounding. So you go to the case 3. This is the last case, and I will try to finish as I saw the time in another 2 to 3 minutes. A 55-year-old male presenting with a history of giddiness, imbalance, sweating, nausea, and pulsating headache lasting 24 hours. Mild giddiness last 2 months, poor lifestyle, work stress, skipped meals, and nystagmus was positive. So if you see differentiating migraine with others, and migraine may be confused with vertigo alone in such cases, and headache may be accompanied with dizziness in 50% of the cases. They are not true vertigos. There is a sense of disequilibrium rather than, as I was telling to you, than the true rotation. Start during the aura phase and may produce spontaneous and positional nystagmus. So vertigo-like symptoms are long, may coincide with the duration of headache, and Hallpike in such maneuvers are negative in such case. So if you see the pathophysiology in this, there is a hyperneuronal activity which stimulate the autonomic centers for control of blood flow in cerebral area. And there are release of the inflammatory markers like substance P, serotonin, and prostaglandin activation. And then these arteries are connected to the afferent fibers of the trigeminal complex, as we know, and cause headaches. And there are other calcium influx, vasospasm, cerebral hypoxia, and aura, which can cause such symptoms. So this is very important. And if you go the international classification of headache disorder, what the migraine is, it is episodic, lasting 4 to 72 hours, unilateral, pulsating, moderate or severe, worse with movements, photophobia, phonophobia is there, may have aura without headache, may have interictal hypersensitivity. There can be cutaneous allodynia in many other patients. So you see there are, despite multiple presentations for headaches, migraine burden is substantial because it is underdiagnosed, undertreated, and considered with various other differential, like I have acidity, I have a gastroesophageal reflux. We have to explain to the patient as a neurologist, whenever you have a migraine attack, your gastric motility decreases. So if your gastric motility decreases, you will feel there is a epigastric fullness which you feel because there is not much of motility there. So a lot of our migraine patient goes to the gastroenterologist and get treated for their acidity or gastroesophageal reflux. So it is very important to identify such patients and treat early so we can reduce the burden of the migraine. And you can see how much big the pie chart is the migraine is taking. So burden of migraine, overall impact of migraine is very high. There is an impact on the work and schooling activity, a lot of burden on impact on the family, and a disease caused when there is a patient is absent for his work. It affects the economy of their house. So any migraine attack, there is a prodrome, aura there or not, there is a pain phase. If you don't give any medication also, in an hour or days, the headache will resolve by itself. If it is the initial part of the life of the migraine, where it comes to the baseline. But as you don't treat it, it never comes to the baseline, and sometimes it goes to the status migrainous. So you can use the ID migrainous screening. Did you ever feel nauseous when you have headache? Do you have light troubles? Did you have headache ever limits your ability to work? So positive answers, 90% sensitivity in this. And another questionnaire whether you have nausea, disability. And disability, you talk about migraine, there is lot of disability, lot of secondary effects coming because of the migraine, like depression because you lose your job. A lot of other factors come in play where the psychogenic overlay comes in the picture in such cases. Now, the last few slides about the outpatient therapy for the migraine, the current and the emerging options. So once I was talking to the cardiologist to have how to treat such patients of headache. So it was a big thing to treat such patients. So, and it has been said that to have a headache is a big headache, but to treat a headache is a bigger headache. That is what I told to one of the cardiologists. But there is very difficult to, can you describe your symptoms? And sometimes patient himself tell their remedies and come with a Google Earth and they do their treatment. So if you see the treatment with the efficacy in the migraine prevention, you have seen anticonvulsant like topiramate and valproate has been used very commonly. But I will tell you the selection of the prophylactic medicine should be tailored according to the patient preference and the side effect profile. So if you see amitriptyline used, you should know that constipation can be there. In the elderly, you should know that there can be delirium, there can be dryness of mouth, which is very important. Like valproate, you cannot give in the young female, you have to see for the polycystic ovarian disease. Topiramate, I have one of my patients, very important, I remember, he's an orthopedic surgeon, and as he don't want to gain weight, and topiramate was given, and when I increase his doses, and suddenly he gone blind, right? So that is very important to know the side effect of the, and we got very scared about him. When we stopped the topiramate, he was having an angle closure glaucoma, which is drug induced because of the cumulative dose of topiramate. So you have to know the side effect profile where the pulse are low. Propranolol has to be taken very careful, and what drugs can cause more sedation, and the compliance of the patient should be very important in such instances. Now, as migraine therapies are improving a lot, the anti-CGRP therapies are there, the monoclonal antibodies are there in market. We have in India, Irinumab. I have few patients on that. It is a subcutaneous injection, 28 days. And one of my patients are definitely doing very good on Irinumab. And there are other which are subcutaneous injection, Galinzumab and Firmenizumab. Then Eptinezumab is a IV medication every 27 days. The important is they are taken only monthly. That is the most important thing, that not every day the medication, and the compliance is good. So the specific therapies are triptan, dihydroergotamine. You know, I told about ergotamine, they can have a background headache. GPANs are the oral new anti-CGRP antagonists, and ditans, like I will talk about lasmiditan. And non-specific UO, naproxen is used a lot and abused a lot, even the paracetamol and with the caffeine. So the pain freedom, if you see after 2 hours with the lasmiditan or the remigipant, which is oral, or ubrogepant are associated with the odd ratio, but compared to the placebo, but they have a lower efficacy than what the triptans are. Triptan's efficacy is much higher than the ditans and the GPANT. You can see on the confidence interval on the opposite side of the graph. All of them favors the treatment, but you see all the triptans. We have used naratriptan, rizatriptan, and even the zolmitriptan, which is there in the both in the tablet form and even in the puff form, and the sumitriptan. And lasmiditan nowadays 50 to 100, and the CGRP antagonists, which are oral, like remigipant, which is being used for the acute attack. So you see the triptan, they have a 24 sustained pain-free response, is very good. And we all have used it and we know about it, but definitely when it is relatively contraindicated for the cardiac diseases, we have to look for the alternative where the GPANs and the ditans are important. So new class of abortive medication like anti-CGRP antagonist, that Remigipant, which is having a very high freedom for the most bothersome symptoms and the freedom from the pain. And even the Lesmetidan in the form of even the 100 milligram, they have a good effect where you cannot use the triptans. So I will close this with the choosing the acute therapy like GPANs. Those are the anti-GRP oral drugs can be used in the contraindication to the triptans and suboptimal efficacy of the triptans and the tolerability issues with the triptans. Otherwise, triptans can be used at the first line. Example like the CV diseases where you should not take the triptans and the ditans, the Lesmetidans, the 5-HT1F agonists, but they do not have the coronary cerebrovascular and the vasoconstrictive effect. So this is how what I was talking about, the transformation of the migraine. They are episodic, they go to the baseline, they convert to the tension type headache, mixed headache, and they become a chronic daily headache. So our neurologist's job is to keep the patient to the episodic migraine. They should not convert into a spouse headache. That is very important to know. So what will be the headache pearls? That is to distinguish the primary headache from the secondary headache is the first objective for every new clinical encounter. And headache is a key headache medicine. 90% are of the primary headache and their examination is normal. And history must be elicited. That is the most important thing. And second thing is to make a correct diagnosis of a primary headache disorder. This is a flow chart. When you need where are the red flags where you need an MRI or imaging or a lumbar puncture, and when there is a worse type of headache, how you have to differentiate them. Otherwise, the migraine, tension type, cluster, TAC, they can be treated like a primary headache, and the right type of the drug should be given. This is very important. Headache diary gives you a lot of things like you should write that what triggers, what medication is relief, are you taking the medication, not. Sometimes you see that their headaches are gone, they stop the medication, and there should be a minimum time of period where they should take the prophylaxis. Are they taking the medication of acute during the initial phase or when the headache is at the peak, how it will be benefited. To summarize my talk, and this is my last slide, all headaches are not migraine and all migraine may not present with headaches. This is the most important statement I want to say to everyone. Migraine may be more often a chameleon than a mimic. Patient history and duration of headaches can be critical decision factors. Migraine treatment options are evolving, both preventive and acute management, as I discussed with you. Thank you very much for the patient listening. I hand it over to Hardik now. Thank you very much.
Thank you very much, sir. And very interesting tools you have shared in your presentation, the ID migraine screener, the migraine diary. I think it is fantastic to have these kind of tools available. And I'm sure the audience has taken note of that and find it very useful. Thank you once again, sir, for sharing these cases and your presentation. So we now move to our next speaker, and we will be discussing more case-based specific details. So our next speaker is Dr. Geronimo Felipe from the Philippines, and she has a very interesting case of a pregnant patient with epilepsy. So over to you, Dr. Geronimo.
Thank you. Good evening, everyone. Thank you, Dr. Hardik. Let me first share my slides. There, can you see my slides?
Yes, Dr.
Okay. So for this evening, I will present a patient of mine who I've been seeing for the past 4 years. So she's ME, a 35-year-old female, right-handed. She's married and owns a small shop near her residence. So history started when she was 3 years old. So according to her mother, she had several episodes of generalized tonic-clonic seizures during the height of her fever. The fever was at maximum level at 38 to 39, and this was associated with cough and colds. So the seizures were, the longest seizure that they were able to recall lasted for more than 30 minutes. Allegedly, it took almost a day before the patient was able to regain consciousness. According to the mother, there was no request for any CT scan or lumbar tap, and she was managed with IV antibiotics and was later sent home with oral suspension of antibiotics. There was no recollection of any anti-seizure medications prescribed to the patient. So the first onset of unprovoked seizures started when she was 8 years old. At first, it was of nocturnal onset, generalized tonic-clonic seizures, which lasted for 2 to 3 minutes. This was followed by post-ictal headache and drowsiness. But later on, most of her seizures are predominantly focal seizures with impaired awareness, described as aversive gaze to the left, with associated facial twitching lasting less than a minute. These are often followed by post-ictal confusion. So this is an EEG done when she was 12 years old. So as you can see, this EEG epoch shows an interictal focal epileptiform discharge on the right centroparietal region with maximal negativity at P4 electrode. At the same year, a cranial CT scan done showing a prominence of the subarachnoid space over the right anterior frontal region, and there appears to be a decrease in size in the anterior frontal area. So this was signed out as microgyri versus encephalomalacic changes. A repeat cranial MRI seizure protocol was requested, but due to financial constraint was not able to do so. So her pediatrician at that time started her initially with phenobarbital, as it reached a dose of 3 milligram per kilogram per day. Seizures were uncontrolled, and so oxcarbazepine was started. At some point, the maximum dose of oxcarbazepine reached 30 milligram per kilogram per day. So with a combination of these two anti-seizure medication, she would have 5 to 6 episodes per month of focal seizures with impaired awareness. So these medications were continued until such time when she was 31 years old that she transferred to my clinic for continuity of care. So these are the issues that we wanted to address when we first met in the clinic. Definitely, we wanted a better seizure control. And at the same time, she complained, or she noticed that when she was 25 years old, she noticed that there was increase in seizure frequency, usually around 3 to 4 clusters of seizure in a day during her period or during her menses. This was in addition to the 5 to 6 episodes per month. She's married. Of course, she was sexually active and she wanted to get pregnant. So given these issues in mind, these are the plans that we want to set. So we target to taper off phenobarbital and replace it with a much safer anti-seizure medication in preparation for pregnancy. At the same time, we wanted to control the catamenial-related seizure clusters. And we wanted to target at least 9 months of seizure-free interval in order to assure or to have a more predictability of seizure recurrence during labor or during labor. So at first consult at the clinic, I started her initially with folic acid at 5 milligrams daily. During the first consult, her mode of contraception was use of condom. Then I started her on levetiracetam 500 milligrams twice a day, on top of the phenobarbital 60 milligrams at bedtime and oxcarbazepine of 600 milligrams twice a day. So in terms of the contraceptive method, it is preferred that she would use a depot injection instead of condom, especially now that we're still trying to adjust her medications, tapering off phenobarbital, and we haven't reached the seizure control that we were aiming for. So I advised her to keep a seizure diary. At the same time, is to log her menses so that we can actually monitor if the seizure clusters are indeed during her cycle. And also, I'd like to have her seen by a gynecologist regarding her choice of contraception. And hopefully she would go for a depot injection instead of an oral contraceptive or condom. So initially, we wanted to see each other on a regular basis, on a monthly basis. However, she was only able to go to the clinic every 3 months. So 3 months after the initial consult, the levetiracetam oxcarbazepine was continued along with the folic acid. And because the seizure clusters continued during her menses based on her seizure log, I started her with cyclic doses of clonazepam at 2 milligrams, 1 for tablet twice a day during her menses. And we started her to, I started to taper off her phenobarbital with a target discontinuation, hopefully within the 6 months period. So we continued her seizure log and menses, and also hopefully she would then find time to see her gynecologist. So after 6 months, her folic acid was eventually discontinued because this is the time that she was already on depot injections. I uptitrated her levetiracetam to 1 gram in a day, in addition to the oxcarbazepine of 2.5 grams in a day, which decreased her seizure frequency from 0 to 1 episode per month. Unfortunately, I had to discontinue her cyclic clonazepam because she was complaining of excessive drowsiness in daytime. So the depot injections was scheduled every 12 weeks. So another 6 months passed. I increased her levetiracetam from 1 gram per day to 1.5 grams a day, and just continued the oxcarbazepine at 1.2 grams in a day, which increased her seizure-free interval from 1 to 2 months. She continued her depot injections for every 12 weeks. So at the dose of levetiracetam, 1.5 grams per day, and oxcarbazepine of 1.2 grams per day, with safely discontinuing her phenobarbital, we were able to reach 13 months seizure-free interval. And so this is the time that she wanted to go back to her gynecologist in order to discontinue her depot and start her prenatal checkups. So at this moment, she is 8 weeks pregnant. I resumed her folic acid at 5 milligrams per day. Despite good seizure control, during the first trimester, I opted to increase her levetiracetam to 2 grams per day, as well as her oxcarbazepine at 1.8 grams per day. And I urged her to have a more regular checkup with me and her OB-GYN. So during this time, the plan was to uptitrate her anti-seizure medication based on the theoretical decline in the serum levels during the first trimester, weighing it with the patient's tolerability and signs and symptoms of adverse drug reaction, and of course, seizure control. Ideally, I would have requested for serum levels of her anti-seizure medications, but this, however, is not available in my area. So this is my last slide. If you have any questions, I'd be happy to answer them. Thank you very much.
Thank you very much, Dr. Geronimo, for this very interesting case. And I think this also completes a loop for us, addressing adult epilepsy, specifically in a pregnant patient, while Dr. Ayaviri discussed about pediatric epilepsies. So thank you very much. And we will come back to you with a couple of questions on this subject during the Q&A session. Thank you. For now, ladies and gentlemen, we will move to the subject of dementias, and we have Dr. Thar Thar Oo from Myanmar, who will be presenting a very interesting atypical variant of Alzheimer's disease. Over to you, sir.
Thank you. Hello, everyone. My name is Dr. Thar Thar Oo, a senior consultant neurologist from Myanmar. Today, I'm going to present a interesting case of a variant of the Alzheimer's disease. It's a case history. Patient is a 57-year-old man who is a well-to-do.
We cannot see your slides. Can you request to please share the screen?
You cannot see the slide.
Okay.
Hold on, just a second. Son of you say.
Not yet.
How about now?
Yeah, we can see your screen now.
Okay.
Yeah. Yes.
Okay. Thank you.
Thank you.
Okay. Thank you very much. My name is Dr. Thar Thar Oo. I'm a senior consultant neurologist from Myanmar. Today, I'm going to present with a case of atypical case of Alzheimer's disease. This patient is a 57 years old right-handed man who presented to the neurology clinic in one of the private hospital in Yangon back in the middle part of the 2017. He's a well-to-do owner of the local jewelry store, married for 33 years. He does not smoke, cigarette, chew betel nuts, or social drinkers. During his first visit, he was accompanied by his wife, and his main complaint was a progressive visual impairment 3 years prior to this presentation. His symptom actually started in the later part of the 2014. That time, he had some difficulty with the using stairs, especially going downstairs. And what he was actually seeing is that he could not see the peripheral vision very well. There's something missing in the part of his peripheral vision fields. No eye pain, no double vision, and that these symptoms are onset of gradual in nature. Because of his vision problem, he went to see the local ophthalmologist and have a thorough ophthalmological examinations. And they were told that everything was fine, except for the very mild cataract. But patient and his wife were advised for the conservative management. His symptom gradually progressed, and in 2015, new symptom develops. Those are he fall occasionally for no reason. He start having a difficulty with driving car, parking in the parking spaces at home and the roadside parking. And the more bothersome was the trouble with seeing most of the objects right in front of his eyes. Because of these progression of the symptom, in addition to seeing the first ophthalmologist, he get the second opinion with another ophthalmologist. Both two ophthalmologists stated that his eyes are perfectly fine except for the cataract. And he was offered for the cataract surgery, and he finally agreed. And then surgery took place around October 2015. Second ophthalmologist ordered a CT scan of the head with no contrast, which reported as a mild cortical atrophy. After the cataract surgery, his vision symptom did not improve and gradually progressed with the new symptoms. New symptoms in 2016 include he's mistaking objects in front of him and not seeing very well, misreach for objects, knock them down, withdraw from his normal cheerful social life, and look very sad by his family. And he looked very depressed because of the family took him to the local psychiatrist. And he was diagnosed with a midlife crisis with a depression, and he treated with an antidepressant. But his symptom did not get better. Near the end of 2016, his neurological and the vision complaints continued to present. Finally, in the middle part of the 2017, he went to see a neurologist in the local private hospital in Yangon. By the time, he noticed that he is getting lost when going to familiar places by driving himself. His writing became very erratic and unable to comprehend some of the written language. He said that he is very depressed due to vision problem and that he is no longer manage his business affair. That time, his MoCA score was 26, affecting the visual spatial, and the MSE score was 27. Mild oculomotor apraxia, stimulanoxia, very mild left upper extremity apraxia was a part in the neurological exam, and the rest of the neurological exam, including the gait, was normal. MRI of the brain was obtained. His MRI showed the left parietal lobe atrophy. The right is slightly worse than the left, and the normal structure in the temporal lobe and the frontal lobes. That time, the local neurologist suspected that might be an atypical or Alzheimer's disease, possibly posterior cortical atrophy. After discussion with the patient and his wife, neurologists advised the second opinion. They went to see a neurologist in Singapore who concurred with the current provisional diagnosis, and the donozepam was started. He and his wife came back to Myanmar. This is his copy of his MRI. You can see he's 57 years old and a pretty much atrophic brain, both in the coronal section, sagittal section, and the axial section. In the first quarter of 2018, one of his daughters who lived in the United States asked them to come to hear the medical checkup. They went there. Before he went, his condition was he stopped driving completely. He very depressed and looked apathetic, and he fall more often than usual. In the United States, he was seen by the behavior neurologist at the academic medical center, and he underwent for the neuropsychological testing. It showed that the impairment of the higher complex visual function, but the rest of the cognitive domains were within normal limits. Because of the finding, FDG PET scan obtained, if we show the right more than the left, posterior parietal, temporal, and the occipital area hypometabolism. CSF biomarkers are also obtained, which show the positive for the amyloid beta and the tau protein. In addition to donozepam, memantine was added, and his final diagnosis that time was an MCI/dementia, non-amnestic single domain visual spatial impairment consistent with the posterior cortical atrophy of the Alzheimer variant. He came back to Myanmar in the early part of 2019, and he lived relatively stable condition. He was last seen in the clinic in the late part of 2019. By that time, his MoCA score was 23, which is slightly decreased, and the MMSE score was 25, also decreased than the baseline. Unfortunately, he succumbed with the COVID-19 infection in the August of 2021. So this is a case of a variant of the Alzheimer's disease called the posterior cortical atrophy. It was first described by Benson et al. In 1988. And the first detailed clinical pathologic report was given by the Levin et al. In 1993. And the prevalence and the incidence of the PCA is currently unknown. Students all reported that out of the 523 patients come to the Alzheimer's clinic patients, approximately about 5% do have a visual presentation, and they also label as a posterior cortical atrophy. The age of onset is much earlier than the typical Alzheimer's disease, averaging about the mid-50s to early 60s. And sex distribution is fairly equal in the male and female, but some of the reports said the slightly female predominance. Typical neuropsychological deficit are visual spatial impairment, visual perceptual impairment, ataxia, some of the features of the Balan syndrome, some of the features of the Gutzman syndrome, and finally, when they progress, they do have a deficits in the walking memory and the limb apraxia. Anterograde memory, executive function, and the linguistic skills are preserved in the early stage of the disease and they gradually affected until they get into the global dementia state. Basic visual processing, such as a form, motion, color, point localization, are usually preserved to a certain extent. In general, all patients with the PCA show impairment of at least one of the basic visual impairment. That suggests that the vulnerability of the fundamental aspect of the vision associated with the occipital cortical dysfunction. Anatomically, as you may be aware of that, Brodmann area 17 is the striatal cortex. And from there, there's a visual association area in the two pathways. The first pathway is a ventral pathway, which is a what stream. And the second pathway is the dorsal pathway, which is a where stream. In patients with the PCA, both pathways are affected. And if someone affected the dorsal type, which is the occipital parietal region, patients usually presented with the stimuloanoxia with a greater atrophy of the dorsal region. And also they do have a Balian syndrome, apraxia, and then neglect. If someone affected the ventral pathway, which is the visual spatial deficits, patients usually present with the visual anoxia, prosopopanoxia, alaxia associated with that. And more or less, these patients can present the occipital damage, and they do have a primary visual failure and impairment of the basic visual skill also. Most of the patients usually present with a combination of the ventral pathway and dorsal pathway, as well as the primary vision areas. And when you look at the MRI, there is an overlap pattern of atrophy is also seen in these areas. Majority of patients do have a normal neural examination in the early stage of the disease. Due to presence of the severe cortical visual impairments, interpretation of the visual acuity and the visual fields are very difficult. When you look at the neuroimaging study on the MRI, PCA patients usually presented with a marked atrophy of the occipital parietal and the occipital temporal region bilaterally, more severe on the right than the left. If you perform the FDG PET scan, PCA showed the hypometabolism in the occipital parietal region, as well as some involvement of the frontal eye fields, but relative sparing of the frontal and the temporal lobes, mesial regions. This is an imaging study of the MR imaging study. The left one is a XRT2 images, and the right one is a coronal flash sequences, and you can see the cortical atrophy in the region, the very full cortical atrophy, and the preservation of the hippocampi. And the neuroimaging study, which show the FDG PET scan and the Pittsburgh compound PET scan, which show the hypermetabolism and evidence of the posterior cortical atrophy in these pictures. Up to this point, genetic identification is unknown, and the PCA phenotypes, no data is available with the PCA phenotype associated with the autosomal dominant family of Alzheimer's disease. But some of the PCA syndrome may be linked to the family of Brown disease, and there might be a genetic component in those subtypes. Pathologically, majority of the patients, the pathological findings is very similar to Alzheimer's disease. Some of them do have other associated neurodegenerative disease, such as a cortical basal degeneration, dementia with Lewy bodies, Brown diseases such as CJD and the family of theta insomnia and the subcortical gliosis. Arena et al. In 2004 reported the pathological data about 21 patients with the PCA, and the majority, approximately about 13, has a typical Alzheimer's disease. Two have a pathological features of Alzheimer's Lewy body variant, and one has Alzheimer's disease with a coexisting Lewy body dementia, Parkinson disease, and the one has a dementia with the Lewy body with a coexisting subcortical gliosis. Two each has a cortical basal degeneration and the Brown disease that include Creutzfeldt-Jakob disease and the theta family of insomnia. In 2017, the classification of the posterior cortical atrophy consensus was published by the Crush et al. Core features for these PCA diagnoses include insidious onset and the gradual progression, presentation of the visual deficits in the absence of the ocular disease, and the relative preserved episodic memory, barber fluency, and the personal insight until the later stage of the disease. Positive pertinent symptoms include visual anoxia, stimuloanoxia, optic ataxia, ocular apraxia, dyspraxia, and environmental disorientation. And these patients must be free from the stroke or the tumor. Other supportive features include alaxia, idiomotor apraxia, agraphia, acaculia, and the age of onset must be under the age of 65, and the neuroimaging study must evidence of the local posterior cortical atrophy or the hypoperfusion in the functional imaging study. So based on that, classification is divided level to 3 levels. First one is whether they do have a core features of the PCA syndrome or not. If someone meets the PCA syndrome, the second level is divided up into two groups, which is the pure PCA, with no other associated neurodegenerative disease, and the PCA plus, which is a PCA with the other associated neurological disease, such as the Lewy body dementia and the corticobasal syndrome. And then finally, final diagnosis of the disease-causing PCA can be divided into four types: PCA Alzheimer type, PCA Lewy body dementia, PCA corticobasal degeneration, and the PCA Brown disease. Among all of them, four of them, PCA Alzheimer type is the most common form. Treatment, up to the date, no treatment is available, but there is a strong pathological association with the Alzheimer's disease. Because of that, acetylcholinesterase inhibitors as well as the memantine can be tried. If someone depressed, antidepressant can be tried. And someone with the Parkinson's disease, it might be worthwhile to try the levodopa or the carbidopa combination. In summary, the posterior cortical atrophy is a clinical radiological syndrome. It's a form of a focal Alzheimer's disease. But it is a very highly disabling visual disorders with the preserve of the cognitive status early in the stage. So very much devastating to the patient and their family. Course of the PCA due to Alzheimer's disease that you can predict pretty much very well, very stereotypic. And patients usually develop memory loss and progression into full dementia in the later stage. When non-AD pathologies caused by PCA, clue for the alternative pathology can be looked. I present a case because up to this point, we know much about the understanding of the basic of the PCA in the recent year. There are state patients that are not able to diagnose or painfully delay in the diagnosis because most of us do not appreciate their symptoms. So my recommendation is the need for the increasing awareness of among clinicians is very much needed among the neurologists, among the general practitioner, as well as the psychiatrists and the ophthalmologists. I include it there, and thank you very much for the attention. Thank you.
Thank you very much, Dr. Thar Thar Oo. Very interesting case on PCA, and thank you for sharing the pearls on diagnosis and management. And we have already received some questions on dementia, particularly from the audience, which we will address to you during the Q&A session. Thank you very much once again. And now, ladies and gentlemen, we move to a totally different topic. We will come back to another case on dementia, but for now we have a series of case presentations on movement disorders by none other than Dr. Bimsara Senanayake, a senior movement disorder specialist from Sri Lanka. Dr. Bimsara, please.
Thank you very much. Once again, I would like to thank you for inviting me for the Neurospace program. So I've been given a topic, a very broad one, to talk on the management of movement disorders in an outpatient setting. So I will try to give an overview of some of the problems that we face with patients with movement disorders in the outpatient setting. Right. So disorders of movement refers to a group of neurological conditions that causes either increased movement or decreased movement, slow movements. So these movements can be voluntary or involuntary. So they may stand alone or can be associated with other systemic diseases. And they may occur due to a wide variety of causes, which are some of them are genetic, metabolic, immune-driven, infective, or inflammatory. And also sometimes it could be idiopathic without a known or identifiable cause. And in the US, it is estimated that about 42 million people are suffering from some form of a movement disorder. So it's a common problem. So broadly, movement disorders are divided into hypokinetic and hyperkinetic diseases. Hypokinetic deals with slowness, basically Parkinsonism and related other Parkinsonian syndromes. Hyperkinetic with increased movement, tremor, dystonia, chorea, ballism, myoclonus, tics, and others like stereotypies, akathisia, and so on. So broadly, they are either hypokinetic or hyperkinetic. So diagnosing a movement disorder is essentially clinical. It's kind of pattern recognition. So taking a history in detail is always a must, and of course examination. A detailed drug history, family history, which might be useful in genetic disorders, essential tremor, Wilson's disease or Huntington disease. Examination might identify the phenomenology, which is the disease pattern, and of course the relationship to other neurological problems in the same patient, and whether it's a standalone movement disorder or a systemic disorder associated with other conditions such as thyrotoxicosis or SLE, and whether the patient also has non-neurological signs along with it. So these are some of the things that we look into in the outpatient setting when a patient comes with a movement problem. So clinical recognition of a movement problem basically has 3 steps. First of all, to identify the individual movement problem or the movement disorder, which we call phenomenology. Then whether we can fit into a syndromic, whether we could recognize a syndrome, and of course, whether a disease can be recognized along with it. So disease recognition based on age of the patient, mode of onset, natural history, response to medications and past history, family history, and so on. All these factors come into play when we try to recognize a particular type of disease which is associated with the movement problem. So we will look into some of the patients and see how we can put them into these categories. For example, this 75-year-old lady presented to us with this movement problem, as you can see in the video. She has a problem affecting the left-hand side of her body, both arm and leg. And the CT scan of the patient is given on the left side of the screen. So clearly you can see a hyperkinetic movement there. So the phenomenology is a very vigorous, irregular, poorly patterned, high amplitude movement on one side of the body, which looks like coriform movements, but it is only on one side. So we call it hemichorea, but it is very fast and high amplitude. So it is known as ballism. So fast chorea or ballism is noted in this patient on the left-hand side. So we call it hemichorea, hemiballism. That is the syndromic recognition. The disease recognition, usually this is commonly seen after a stroke in this age group, involving the appropriate area on the contralateral side. But in this case, as you would have noticed, there was a hyper density in the basal ganglia region, which indicates that it is unlikely to be an infarction. So this patient actually is a diabetic patient who has poor diabetic glycemic control, and this has led to this condition known as diabetic steatopathy, causing hemichorea, hemiballism. So this is generally seen in Asia, mostly in elderly females with type 2 diabetes. So that is how we make a diagnosis there of hemiballism and hemichorea, looking at the phenomenology of the patient. So we go into another case where we try to categorize the patient here with again affecting the left arm, mainly the left upper limb. You can see a movement there, and that again looks like a hyperkinetic movement affecting only one side of the body, mainly the upper limb. And so in this case, it is more tremulous, and patient seems to be having all different types of tremor, resting tremor, action tremor, intention tremor, as well as what we call bat wing tremor or wing beating tremor. So all different types of tremor are noted in this patient's left upper limb. And on the left side of the screen, there is a brain scan with some lesion. So the clinical recognition here is the phenomenology is irregular unilateral high amplitude tremor with some wing beating movements as well. And it has all different components of different types of tremor. So hence we call this Holmes tremor, which was initially described by Gordon Holmes in 1904. Also, this was previously known as rubral tremor, mesencephalic tremor, thalamic tremor, and so on. So in this case, there are many conditions which can lead to this, like stroke, tumors, trauma, cerebellar lesions, and so on. However, in this case, the CT shows a brain stem hyperdensity and speckle calcification with the so-called popcorn appearance on the MRI, which basically indicates that the patient has a brain stem cavernoma, which has led to this. So that is the disease recognition in this case. We go to another case here of a patient whom we saw recently. So this patient, if you carefully observe, has a movement which comes in episodes. There you are. So you saw something happening to the face as well as the right upper limb suddenly, for a brief moment, suddenly jerked and moved away. And now it happened on the left-hand side as well. So this is a 55-year-old lady who presented with some behavioral changes as well. With this sudden movements, abrupt onset movements happening both sides. So these are unilateral short-lived dystonic posturing kind of movement involving the upper limb and the face. So syndromically, this can be called a dystonic seizure, categorized into dyskinesia, involuntary movements, stereotypies. All these can be seen in dystonic seizures. And this is a fairly characteristic, distinctive type of movement, which is known as faciobrachial dystonic seizures, which is associated with a type of autoantibody causing a immune-driven encephalitis, autoimmune encephalitis due to AGI1 antibody. So this is, however, this is usually unilateral, but in this case, is a very rare case where it is seen bilaterally. So the characteristics of movement disorders depends on the speed, the amplitude, rhythmicity, whether it's rhythmic or not, large amplitude or not. So we have seen fast chorea, large amplitude chorea, which is ballism. Speed, if it is slow, it is hypokinetic. If it is fast, hyperkinetic, and so on. So this is the way they are categorized into different ways. The movement disorders can be further categorized. So now sometimes it can be inhibited voluntarily, some of the movement disorders. Now you can see here this young man has what is known as a dystonic movement in the head, the dystonic head tremor as well. And he keeps his hand around his, on the left-hand side of his face, just to try and avoid getting the movement. So this is called a trick movement, which basically is an attempt to stop it. So involuntary shaking of the head with the intermittent neck movements as well, with a head tilt. So we call it cervical dystonia with dystonic head tremor. And the trick movement also is a feature of this condition. So this can be idiopathic or associated with many other conditions, as I will be showing shortly. Now, this man also has a similar kind of a movement involving the head. It's a dystonic head, of course. But in addition, as you can see, there's a oromandibular or orofacial dyskinetic movement, orolingual as well. So this patient actually had about 25% of his red cells were acanthocytes. So this is what is known as neuroacanthocytosis. Again, you can present like this, just with the cervical dystonia and dystonic head tremor with orofacial lingual dyskinesia, and underlying problem can be something like neuroacanthocytosis, which is a well-known condition. It has diversity genetically, and there are 4 different patterns recognized: chorioacanthocytosis, Napoleon syndrome, PCAN, which is an NDIA, and brain accumulation syndrome, and Huntington disease like type 2. So all these will have acanthocytes in their blood picture. So this is another patient with the same problem. You can see that he also has these orolingual, orofacial dyskinetic movements, and he interestingly had nearly 70% of his red cells were acanthocytes. So it's a severe case of neuroacanthocytosis, and this is the way he walks. This can easily go for a non-organic kind of gait, but actually this is classic so-called rubber man gait seen in patients with neuroacanthocytosis. So he has kind of self-mutilated, his teeth are all gone, and so there is a significant amount of trauma in the mouth, damage to the gums as well. So this is another patient who had who presented initially many years ago. Actually, I first saw this patient about 17 years ago with dystonic right upper limb. Later on, she started developing this dystonic head movement. Then, interestingly, in imaging, there was this so-called tiger's eye sign, which is indicative of iron deposition, causing these movement disorders associated along with it. So this is a type of the commonest type of neurodegeneration with brain iron accumulation known as PCAN. So this patient, we genetically proved that the patient has this condition. So dystonia is a neurological disorder where the muscles go into spasm and they sometimes start shaking. There is a dystonic tremor, and that part of the body can be painful also due to spasm. So it can involve the arms, legs, trunk, eyelids. Any part of the body can get involved. It can be focal if it involves one part of the body, like neck, spasmodic torticollis or cervical dystonia, eyelids, blepharospasm, lower face, Meeks syndrome, and so on. So this is a patient who had a problem with his writing. So you can see he's struggling to write. He's got a spasticity or spasm involving the right upper limb, making it difficult for him to write. So this is known as writer's cramp, which is task-specific dystonia. Sometimes you see it along with also with playing musical instruments, which is known as musician's cramp. So this one, as you can see, two patients actually with the same problem. So they are both struggling to keep their eyes open because the eyelids are twitching a lot. So it's bilateral. So struggling to keep the eyes open. So severe form of blepharospasm, which is a focal dystonia. So it can be, it is usually bilateral as opposed to hemifacial spasm. It's a focal dystonia. It can be essential without any cause, or it could be associated with other conditions like progressive supranuclear or also what is known as Meigs syndrome. So this case, again, the patient has blepharospasm. However, there is, in addition, there's some oromandibular dystonic movements as well, which is known as Meigs syndrome. Another form of dystonia, two different types of dystonia in the same patient. So this one, again, is a form of dystonia. She cannot keep her head straight, keeps falling backwards. So this is known as retrocolis and is usually drug-induced. So the form of tardive dystonia. So retrocolis is almost always secondary to drugs like antipsychotics. So there are different types of dystonia in the neck, as you can see in the picture. Lateral colis, retrocolis, anterocolis. So this gentleman also presented with some tremulous movements in the upper limb, as you can see here. So he's struggling to keep his. So it's kind of a low frequency, high amplitude, posture-induced arm tremor, elicited by sustained abduction of arms and flexed elbows, arms facing down, flexed elbows, struggling to keep the arms that way. So you can see that happening on both sides. You saw something like that earlier in a patient on one side, but here it is happening on both sides. So this is the same patient after treatment. So he has completely got over the problem. So this is another patient whom we saw in the clinic with a similar kind of issue. You can see, and the ophthalmological examination shows that. So another one, another one of our patients. So this is a characteristic whim beating tremor, as we saw in the previous patient also, seen in Wilson's disease. So in all young onset movement disorders, it is a must that you screen for Wilson's disease. We do this for all our patients with whatever the movement disorder, because they can have all kinds of phenomenologies with Wilson's disease. So it's important to exclude it in all cases. So generally we do Wilson screen, a copper screen in all such patients, and also blood picture to ensure that they don't have acanthocytosis, and maybe we do ferritin levels. Now, it is not always easy to diagnose this condition. As you can see in this case, this is a patient whom we saw with a tremor. This is the tremor she had, going on for many years. And she did not have a K-ring. As you know, that the patients will, generally with neuro-Wilsons, most of the patients will have what is known as a K-ring. But some of them very rarely may not have a cave ring, but still will have some features, neurological features. But in this case, the tremor was very subtle, more like an essential tremor. And however, the imaging initially was looking more like Wilson's disease, with giant panda sign and so on. But later on, as time went on, it was looking a bit like neurodegeneration with iron deposition, which sometimes happens in chronic Wilson's disease. But here in this case, it was difficult. We had to do the genetics to confirm the diagnosis, because most of the time we don't have to do the genetics in Wilson's disease to make a final diagnosis. But in this case, since there were no cave rings and the features were very subtle, we had to do a genetic test. So, as I said, Wilson's disease can be associated with iron accumulation in basal ganglia. So sometimes you can get confused, because this was initially thought to be neurodegeneration in iron accumulation. So there are certain characteristics described in patients who are having neuro-Wilsons without cave rings. So this may have higher ceruloplasmin levels. So as it may be maybe a milder form of the condition, and cirrhosis of the liver, typical MRI signs also may not be there. Maybe in the initial stages we are detecting them. So talking about genetics and movement disorders, nowadays, of course, movement disorders is all about genetics. I think it's becoming increasingly common for in high-end movement clinics to go for genetics in most cases. This is another case of a young girl with the problem, previously healthy, progressive memory problems, difficulty in walking, visual impairment, slurring of speech, poor school performance, consanguineous. However, no birth insult also. She has a positive family history as indicated below. So marrow showed the so-called sea blue histiocytes. And finally, genetically it was confirmed that she had Niemann-Pick C disease. So she presented to us with those features. Another patient, young girl, with a similar genetically driven problem, having a combination of two phenomenologies, dystonia as well as bonus. And this is a very rare genetic disorder due to SGEC1 mutation, PYT11. So she has cervical dystonia and myoclonus. So this is another type of problem that we see in our clinics. Tics, motor tics. Usually, if you are going to diagnose this condition, we have to ensure that the patient has got it before the age of 21. Symptoms usually persist for at least 12 months. There can be associated other behavioral problems like OCD, ADHD, learning disabilities. Again, I think it is genetically driven. Quite a common problem that we come across in our outpatient clinics. This is less commonly recognized problem. Sometimes patients come out with it. painful legs and moving toes. This is seen in clinics. Sometimes the patients, however, in this part of the world, sometimes they may not complain about this, but it's a well-known movement problem known as painful legs and moving toes. Then, of course, we have to move on to the other important portion of movement problems that we see in clinics, which is functional movement disorders, which is about 10 to 15% of our patients with movement diseases. So now it is recommended that we make a positive diagnosis about functional movement disorders in the clinics using various signs for different types of functional movement problem. It could be a tremor, functional dystonia, functional myoclonus, functional gait disorders, functional Parkinsonism, and functional chorea. So all these different types of, the most frequent, of course, is tremor, followed by dystonia and myoclonus. Most of these things will have their own different signs that we use. Those are positively diagnosed using those signs without waiting for, without trying to exclude other causes. It's no longer considered a diagnosis by exclusion, so it should be positively diagnosed. So I'll just show some of the cases that we have seen. So some of these functional problems. So this is a patient whom we saw in the clinic with something looking like a hemifacial spasm. She insisted on botulinum toxin injections, and we had to oblige also. Since it was useful because she got better within one day. So that's one patient like that. Now this is another one with a similar problem. So this also looks like maybe a hemifacial, but this one is now completely well after actually SSRI was prescribed by another neurologist, so it got better with this. So so that's that one. So this one is another very interesting case actually. Another facial problem. It's a difficult movement to do, but anyway, so these are some of the patients whom we saw recently with some facial. So you can have different types of functional movements in the face, many different types. So these are some of them. Right. So we just conclude there. So I have tried to give a very broad outlook about movement disorders that we come across in movement clinics and how we deal with it. The summary, of course, is that the important thing is to make a proper diagnosis. Diagnosis is not always easy, as you just saw in some of these videos. It is a clinical diagnosis, almost always. So that is the difficulty in some of these conditions. Of course, sometimes supported by neurological investigations and radiology. So a diagnosis is essential, and most of these conditions can be pharmacologically treated. Most of the dystonias also can be successfully treated with botulinum toxin and so on. And if you can find the underlying cause, it is important to treat the underlying cause, like in Wilson's disease. So, what again I would like to emphasize that the diagnosis has to be made properly. Sometimes it's about pattern recognition. So experience matters as well, and also the fact that if they are being evaluated in dedicated neurology clinics or movement clinics, chances of making a proper diagnosis is always. So I think I have given a very brief overview of movement problems that we see in clinics. So I hope there was something useful in this presentation. So once again, I would like to thank the organizers, Neurospace and Dr. Hardik for inviting me. Thanks a lot.
Thank you, Dr. Bimsara, and thank you for taking us through a series of cases ranging of different movement disorders beyond Parkinson's disease. Thank you very much, and we'll come back to you with a few questions on the subject. For now, we come to our last case presentation for the day, that is by Dr. Denise Pedra. Dr. Denise Pedra will be delivering her talk in Portuguese.
Bom dia a todos, meu nome é Denise Lutfi Pedra, eu sou neurologista, pós-graduada em geriatria e gerontologia. Hoje eu trouxe um caso clínico para a gente discutir de uma paciente que compareceu ao consultório com uma queixa de esquecimento. Tá? Vou compartilhar aqui com vocês os slides. Bom, essa paciente é uma paciente de 74 anos, ela é uma servidora pública aposentada, estudou durante 12 anos em ensino formal, e a queixa dela, compareceu ao consultório, foi de esquecimento, né? Ela nos contou que há aproximadamente um ano ela vinha apresentando dificuldade em achar palavras, não lembrava onde colocava objetos e que vinha esquecendo fatos recentes. Muitas vezes era dada uma informação nova a ela, ou um recado para ela dar para alguém e ela se esquecia. Ela foi acompanhada da filha e, de acordo com a filha, na verdade, esse quadro já vinha há 3 anos, e ela mesma já observava que a memória dela não era mais a mesma, ela não era mais a mesma pessoa, porém, nem ela nem a filha deram muita importância a esse quadro, visto que ela conseguia realizar todas as tarefas de casa. Então, até então, ela achou que isso pudesse ser alguma coisa relacionada ao próprio envelhecimento, né? Porém, no último ano, a filha percebeu que ela começou a errar coisas básicas, como, por exemplo, receitas que ela estava muito acostumada a fazer, trocando ingredientes. Ela começou a ter problemas com as finanças e esquecer de pagar contas e ter problemas com troco, e começou a ter dificuldade em usar o cartão no caixa automático, inclusive tendo a sua senha bloqueada. O que a gente observa, então, quando o paciente chega ao consultório com essa queixa de esquecimento, é que é importante a gente entender se isso poderia realmente ser relacionado ao próprio envelhecimento, ou a gente está com um paciente com transtorno subjetivo de memória, ou até com comprometimento cognitivo leve, e, quem sabe, com um quadro realmente demencial. Então, esse paciente, quando chega no consultório, primeiro a gente vai observar, ele veio sozinho ou veio acompanhado? É claro que não necessariamente o paciente que vem sozinho, ele apresenta-se com a cognição boa, né? Muitas vezes, claro, isso vai chamar a atenção para a gente, que é mais provável que um paciente que venha sozinho, ele esteja com uma alteração cognitiva menor, né? Mas o que a gente observa é que, na maioria das vezes, o paciente que tem um envelhecimento normal e a queixa não é por um quadro demencial, ele muitas vezes comparece sozinho ao consultório. E ele tem uma preocupação com a memória maior do que as outras pessoas, até os próprios familiares, né? Ele consegue detalhar como é esse esquecimento dele, inclusive dar exemplos de como isso se apresenta. Apesar de que ele possa vir a repetir o que ele já disse durante a consulta, a gente percebe que isso é mais um reforço, né? Como eu disse, não é aquela pessoa que repete porque realmente esqueceu o que falou. E dificilmente ele vai falar não sei, como uma resposta a uma pergunta feita. Inclusive, na maioria das vezes, ele acaba tendo respostas mais longas e inclui detalhes adicionais que não foram perguntados, né? Com relação ao acompanhante, seja um informante, seja um cuidador, seja um familiar, o que a gente observa é que ele vai se limitar mais a confirmar ou não a informação que o paciente deu e a oferecer uma segunda opinião, né? A gente não tem aquela situação que a gente vê muitas vezes com o paciente demenciado, que é de virar a cabeça, né, para perguntar alguma coisa para a pessoa que está acompanhando, como se ele quisesse que a pessoa respondesse por ele ou lhe ajudasse a definir aquela situação, né? A gente vai perceber também que dificilmente o que o cuidador, né, ou o acompanhante fala é diferente do que o paciente fala. E a gente não vai perceber que ele precisa ajudar ou assistir o paciente a responder perguntas de cunho pessoal. O que a gente não vai esperar num paciente com envelhecimento normal que está se queixando de esquecimento? Alterações, por exemplo, de linguagem, né? Nem alterações relacionadas a tarefas que você precisa apenas de um aprendizado motor, né? A não ser que você tenha, no caso, um paciente com alguma limitação de outra ordem, né? Então, por exemplo, você pede para o paciente fazer um movimento aleatório com as mãos e ele vai saber fazer normalmente aquela tarefa, né? Da mesma maneira, você não vai ter dificuldade para que esse paciente reconheça ou localize objetos, a não ser que realmente ele também tenha alguma queixa visual. É claro que muitas vezes esse paciente que chegou ao consultório com uma queixa de esquecimento, ele pode ter um declínio cognitivo subjetivo. Esse é um diagnóstico importante em vista de que esses pacientes serão os pacientes candidatos a utilizar uma droga modificadora da doença, né, quando ela estiver disponível, e são pacientes em que você ainda consegue ter um paciente com uma queixa, né? Mas não tem um prejuízo funcional por conta disso. Então, é um paciente que ele percebe que a memória dele mudou, isso pode ser ou não confirmado pelo informante, mas ele consegue situar isso no período de tempo, né? Então, ele consegue dizer quando foi que isso começou, como que isso se apresenta, inclusive dar exemplos do dia a dia. Então, pode dizer, eu esqueço o nome de pessoas conhecidas, por exemplo, não consigo me lembrar do nome de artistas, alguma coisa nesse sentido, né? Pode ter, né, quando ele começa a perceber essas alterações de memória, ele pode ter um quadro de ansiedade associado. Não é para a gente esperar que esse paciente tenha alteração em testes objetivos de memória, por isso que é um declínio subjetivo, e ele não vai apresentar isso num teste de triagem, mas muitas vezes, quando ele é submetido a testagens mais complexas, ele realmente pode apresentar algumas alterações sutis. E se ele for investigado, por exemplo, com biomarcadores, no caso, com exame de líquor, ele pode apresentar alterações do espectro da doença de Alzheimer, e aí seria um paciente realmente que está a caminho, talvez, de um comprometimento cognitivo leve e, posteriormente, de um quadro demencial. E o paciente com comprometimento cognitivo leve, ele realmente vai apresentando uma perda progressiva da cognição como queixa, e ele vai ter essa queixa confirmada pelo informante, né? Essa queixa, a princípio, pode ser de memória, visto que os quadros amnésicos são os mais comuns, mas você pode ter um comprometimento cognitivo leve de outro domínio ou de múltiplos domínios, e aí você pode ter alterações na função executiva, na linguagem e na praxia, né? Não é de se esperar que esse paciente tenha nenhuma alteração intelectual globalmente, e uma das coisas importantes é que ele não vai ter prejuízo funcional, né? Se ele já apresentar algum tipo de prejuízo funcional, então a gente já tem que pensar que esse paciente tem um quadro demencial. E aí, voltando à nossa paciente, Ela é uma paciente hipertensa, diabética, faz uso de losartana, 50 miligramas ao dia, e metformina, 500 miligramas, 3 vezes ao dia. Ela tem uma história familiar de uma irmã que teve doença de Alzheimer, e os exames sanguíneos dela, tanto o hemograma, creatinina, ureia, o hepatograma, as funções tiroidianas, vitamina B12, ácido fólico, BDRL e os minerais, potássio, sódio, cálcio, todos foram normais. Ela tem uma glicose aumentada, uma glicemia de jejum de 113, e o exame físico e neurológico dela mostrou que ela é uma paciente obesa, que tem uma pressão arterial de 140 por 90 milímetros de mercúrio e apresentava parestesias em membros inferiores com uma provável neuropatia diabética. O exame do estado mental dela mostrou no mini exame 22 pontos em 30, o que então nos remete para um determinado diagnóstico, né? Continuando o caso, essa paciente apresentou no teste de fluência verbal de animais, 11 animais em 1 minuto. O teste do relógio, ela teve 8 pontos em 10. A gente sabe que o teste do relógio ele é bastante sensível, principalmente quando você tem um paciente com comprometimento cognitivo leve. Isso tem uma sensibilidade para a virada para a demência, né? E no teste de figuras, ela teve uma percepção visual e uma nomeação de 10 em 10, mas quando se avaliou a memória, tanto imediata quanto incidental, ela só acertou 4. Com relação ao aprendizado, 5 em 10, com relação à memória tardia, 4, e com relação ao reconhecimento, 5. Na avaliação neuropsicológica, basicamente, o que a gente observou? Que ela tinha uma alteração, uma fraqueza na fluência semântica, bem como na flexibilidade cognitiva e nas habilidades visoconstrutivas, mas o que chamou bastante atenção é que ela tinha uma alteração de memória episódica, com dificuldade tanto de codificação quanto de estocagem de material a memorizar. Foi, então, concluído que ela tinha um CDR de 1, e ela apresentava também uma ressonância magnética com uma discreta microangiopatia, mas com um certo grau de atrofia cortical e hipocampal, né? Na escala visual, ela tinha uma assimetria, sendo o hipocampo direito grau 3, um MTA 3, e o hipocampo esquerdo, um MTA 2. Ela tinha também um SPECT, né, uma cintilografia, com uma hipoperfusão temporoparietal direita. Então, a hipótese diagnóstica dela foi para uma doença de Alzheimer, na fase leve, e a proposta terapêutica, então, foi a ribastigmina em PET de 5 centímetros. Essa paciente, apesar da escolha ter sido pelo PET, ela apresentou uma leve náusea que não precisou de descontinuação do tratamento, nem de tratamento específico, né? Essa dose da ribastigmina foi, então, aumentada no período de 4 semanas para o PET de 10, e ela foi reavaliada depois de 3 meses de tratamento, onde se mostrou, segundo a família, uma melhora funcional, e o mini exame de estado mental dela, então, foi de 23 pontos em 30. Essa paciente manteve esse quadro estável nas consultas subsequentes, então, ela foi reavaliada aos 6 e aos 12 meses e manteve esse mini exame de estado mental em 30. Depois de 18 meses, ela começou, então, a apresentar uma piora progressiva, tanto cognitiva quanto funcional. Então, ela começou a precisar que se ajudasse na escolha de roupas, ela muitas vezes tinha dificuldade até para se vestir, começou a esquecer de usar a descarga do banheiro, tinha dificuldades, por exemplo, no uso de eletrônicos e até de eletrodomésticos, né, que ela usava com frequência, e o mini exame de estado mental dela, então, caiu para 19 pontos. Ela começou a apresentar perambulação, ansiedade, algumas ideias paranoides e começou a ficar agressiva quando era contrariada, né? Nesse aspecto, então, foi solicitado que a gente atuasse, e aí a gente teria algumas opções, ou de aumento da rivastigmina para o PET de 15, né? Ou a introdução de alguma medicação antipsicótica, ou a introdução da memantina, que foi a nossa escolha, né? Então, nós introduzimos a memantina no incremento de 5 miligramas semanalmente, até a chegada de 20 miligramas, e a gente sabe que muitos estudos mostram que a terapia combinada dos anticolinesteráseos com a memantina, ela é melhor do que a terapia isolada do anticolinesterásico, tanto no perfil comportamental, quanto nas atividades de vida diária. Essa associação ela é utilizada na fase moderada grave, essa paciente já tinha 19 pontos no mini exame de estado mental, é uma associação bastante segura e bem tolerada, mostra resultados principalmente na cognição, na capacidade funcional, mas de forma bastante importante nas alterações comportamentais. Então, muitas vezes a gente vê uma melhora desses quadros de agitação apenas introduzindo a memantina, e isso diminui a sobrecarga do cuidador. Dá mais tempo de autonomia para esse paciente e nos dá tempo de aguardar terapias para modificação da doença, né? E a gente consegue, manejando essas drogas que a gente tem, trazer algum tipo de benefício para esse paciente. Essa paciente teve uma melhora do exame dela de 20 para 30 pontos, uma melhora pequena, né? Mas a família reportou para a gente que ela teve uma melhora funcional e na participação ficou mais comunicativa, né? Teve um ganho de vocabulário e o mais importante é que ela melhorou dos sintomas comportamentais, não precisando, então, a gente introduzir nenhum medicamento psiquiátrico. Então, era esse o nosso caso. Muito obrigada.
Thank you, Dr. Pedra, for that case. And with this, I'd like to thank all our speakers for generously sharing all the information. And now we are ready to begin the Q&A. So I will request all the speakers to please switch on their videos for the panel discussion. And I will request the audience to please post their questions in the comments box, which you can see at the bottom of your viewing screen. If you can just scroll down a little bit, you will see the comments box. Meanwhile, we will begin with a few questions already received in advance, but just let me request the chairperson, Dr. Arvind Sharma, to share the results of the poll first, which he conducted during his talk.
So the poll results definitely 33% has told cluster headache. So it's totally okay. For both the cases, it was 33%. The results were. I think this talk may have enlightened more. Thank you.
Yeah, thank you, sir. So, sir, let us begin with the questions on headache that we have received for now, and two very interesting and very common questions which have been always asked about headache management. One is how long does one need to give medication for headaches? I think it's a very broad question, not specific to a particular type of headache, but I request you to please take this up.
No, thank you, Adik. And I think who has asked? Dr. Hin?
Yeah, Dr. Hin Tezo.
From
Myanmar.
Myanmar. So thank you very much for the questions. So it exactly, you have pointed right. It depends on the type of headache, right? If it is migraine, then 6 months to 1 year is the prophylaxis. It depends on the number of frequency of the headache in a month, right? If it is more than 3 to 4 per month, then you give the prophylaxis. But if it is a kind of a tension headache, right, you give the SOS medication to them, and then you don't do any medication. So it definitely depends on the type of headache. If they are primary headache, then for prophylaxis it is different. For acute therapy it is different. But those who are not having headache 1 per month, you don't start prophylaxis in migraine. For a cluster headache, it is very periodic. Periodicity is there. So definitely the line of management changes in place.
Right, sir. Thank you. And another question is about preventive therapy for migraine during pregnancy. I think this is a very pertinent question.
Nahi, that is, thank you for this question is again from
Again from Myanmar, Dr. A. Mya Nin.
very senior neurologist there, what I know of, right? The question is very pertinent and very important, right? For the treatment of migraine in pregnancy. Generally, you try to avoid any drug during the pregnancy. You can give paracetamol if needed. But if at all, I think Dr. Alessandro has mentioned about lamotrigine. It also have a very good anti-migraine effect also. When he talked about in the pediatric epilepsy, he told that is a very safe medication. And many of our patients are on lamotrigine for headache also. They do really. And another medication which is safe is the amitriptyline.
Okay. Thank you. Thank you, sir. Sir, while we are receiving a lot of questions from Myanmar, so I'll direct the next question to Dr. Vijay Sharma. Sir, I think the next question is about the first case that you presented. Which factor led you to do the angiogram for the Chinese student?
I understand you're talking about the Chinese student who were having handshaking.
Handshakes, yes.
That was a very, very interesting case. We do a lot of transcranial Dopplers. We do a lot of research involving transcranial Doppler. And at that time, we were having a small research project that we were talking about what happens to the blood flow in patients when they get seizures. And the other thing was that, whether during seizures, just before seizure, our hypothesis was that seizure activity means that you are having a brain which is metabolically very active. So brain needs to increase blood flow. And we were looking basically at patients with non-convulsive seizures, whether we can diagnose them without doing anything, just with doing a TCD. So this girl was there, and when we were doing the EEG, we knew that there was slowing, and we just were very curious to know why is this girl having a slowing on the left hemisphere. And looking at that, we just put the TCD probe, and the moment I put the probe, I saw the blunted flow in MCA. And the moment I saw blunted flow, I told, because initially our epileptologist said that, let us work it out further for some kind of epilepsy, although clinically it does not look like. But the moment I saw the blunted flow, I said that this is not epilepsy at any cost. You need to give this patient to me, and I need to do an angiogram. I am not interested in seeing the MRI. But since MRI and MRA, they go as a bundle investigation. This is how the MRA was done for this patient. But even if there was a simple MRI done for this patient, it would have shown the flow voids abnormal in the left MCA, because this was quite a proximal occlusion. So it would not have been missed even if there was no angiogram done. But it was all by chance. It's not that it was just diagnosed.
Yes. Thank you, sir. Sir, we have a couple of more questions on movement disorders. Well, we'll come back to that later. For now, I want to go to Dr. Thar Thar Oo.
Hardik, just one comment, about the previous patient,
yeah, sure,
about the medicines for headache prevention in patients who are having pregnancy.
Right.
So, our approach has been very, very clear. You are worried during only the first trimester. And even in the first trimester, first 8-12 weeks, when the organogenesis is happening, that's the only time when you're worried about the drugs. But beyond that, most of the drugs are safe. They do not matter much, actually, if you're going beyond that time. But just try to avoid all possible medicines during the first trimester. Even lamotrigine, you cannot say that this is absolutely safe drug. All right. So, but definitely this is one of the safer anti-epileptic drugs during pregnancy, and a lot of our patients, they stay on it, on this. We have tried magnesium sulfate in some of the patients' pregnancy. Difficult to control headaches during the first 3 months, which is absolutely safe chemical. But beyond the first trimester, most of the people, they are not much worried about using some of the other drugs.
Thank you,
So,
sir. Thank you
yeah,
for
I
highlighting
think
that.
to add to it, and Dr. Vijay has told absolutely right about it, and it is an important point. The only point which neurologists should remember when they are prescribing the medicine, first 4 weeks are gone when they come with a pregnancy. So it is very important when you're prescribing any, because migraine, you prescribe propranolol, right and left, right? Propranolol, topiramate, and you give it to them, right? And they come with that pregnancy. So that 4 weeks, which Dr. Vijay has mentioned, so you have always to ask a young female that are you planning, right? So I will change your medication or I will stop your medication. That will increase your headache. So that first month, that's for first 4 weeks, where they come with the missed cycle, you're gone. So that is important to mention.
Right. Thank you, sir. Thank you. Dr. Thar Thar Oo, the questions we have received are on dementia, not particularly PCA, the case you presented. And the question is from Professor Moy Moy Zo. Why dementia patients repeatedly ask the same questions?
Thank you very much for this question. Most likely they cannot retain the new information. So that is the most important thing. To integrate amnesia. That is one of the reasons that they once they were told about the new information, they cannot retain. But they have a good memory about the long time memory. So most of the family in Myanmar, and when we ask, how about the memory? And the family said, oh, very good. She can tell, or he can tell exactly when, where, 15 years ago, that what happened. But how about the event for the yesterday? And they forgot. So this is the main thing. It's a salient point of the anti-great memory problem in the dementia.
And another question for you, Dr. Thar Thar Oo, is about the role of citicoline, its use and benefits in patients with AD. What is your experience with that?
Citicoline is a very good drug, as you may be aware of that it is a neuroprotective and neuroregenerative drug. So in addition to the cholinesterase inhibitors and non-selective MNDA antagonists, I use it quite a bit as a kind of like hoping that they will help for do the kind of like when you're in the brain, you have a free fatty acids radicals, free radicals. So by doing that, by decreasing that, you kind of like you give you some protection, and also it helped for the neuroplasticity. It helped for the neuroplasticity. So this is two reasons that I would use that. Whether I can prove in the scientifically or not, I don't have an answer, but it helps to some extent. I do believe in that.
Thank you, Dr. Thar Thar Oo. Now we move to a few questions on the subject of epilepsy. Let me bring in Dr. Alejandro from Mexico. Dr. Alejandro, we have received a question which says, have you come across forced normalization in pediatric patients with drug-resistant epilepsy? If so, how do you deal with it?
Thank you for that question, Dr. Hardik. Fortunately enough, the answer is no. I have not. I mean, I know this is a possibility that can happen with some patients, that when resolving seizures, some psychiatric comorbidities could appear, and they will sometimes need to be addressed, withdrawing the anti-epileptic suspected of having causing this psychiatric disorder, and sometimes even adding an antipsychotic to the medication. Fortunately enough, even though there are reports in children, me myself, I have not been able to know, or I have not had the opportunity to manage one of these patients. We do see other kind of neuropsychiatry disorders sometimes associated We have seen neurisis associated with the use of levetiracetam. That's not too well reported in the literature, but we have seen it sometimes. But no, psychosis in children are not that common. So, I mean, I'm sure my colleagues that attend older patients are more likely to have encountered this, but in pediatrics, we don't see that much.
So, Dr. Geronimo, before I go to the specific question that has been raised for your case, would you like to comment on this same issue of forced normalization in epilepsy patients?
Yes. Good evening, everyone. Thank you for that question. Actually, it's always a challenge for every neurologist every time that our patients with epilepsy will have a comorbidity, a psychiatric comorbidity. It's hard to separate if it's something pre-ictal, ictal, or post-ictal. So in the first question, yes, I actually have experienced a patient with forced normalization, both for adult and pediatric patients. In this area where I stay in, we don't have a pediatric neurologist. So there are some patients, pediatric patients that are referred to me because of, a sparse number of pediatric neurologists in the area. So there was this patient with a case of, if I'm not mistaken, she was 8 years old, and she was referred due to seizures that are more of psychiatric in nature. So initially, she will have fearful ictal, and then she will have automatisms. And then there was sudden decline in speech as well as imbalance. And then when the EEG was done in my hospital, luckily enough, though it was a routine EEG, she was asleep the entire time. And it was a type of EEG that is consistent with electrical status epilepticus in sleep. She was at the time already on valproic acid. She was a female patient. So I opted to start her on top of that valproic acid with another broad spectrum anti-seizure medication, which was levetiracetam. In a matter of 2 weeks, it did control seizures of the patients. There was improvement in speech as well as in ambulation. She was no longer ataxic. However, she started to have bouts of aggressive behavior. She often bit his parents. She will often have triggers of delirium. So it was at the time now a question of whether these are still part of her ictal seizures or post-ictal. So I repeated the EEG, but at this time, though she was asleep during the routine EEG, there was less area, the resolution of the previous status epilepticus in sleep. So luckily enough, I have a friend near the area who was a neuropsychiatrist who started her on antipsychotics. It was a choice between controlling the seizures with the improvement of her speech and ambulation with just managing her symptomatically for the meantime. Though it's a hard case, there's really no consensus, so it's a case-to-case basis.
Very interesting. And Doctor, how would you say, with respect to the case you presented, if the patient also had psychosis as an additional comorbidity, how would you have managed it differently?
Yeah. So every time you are faced with a patient with previous known history of epilepsy, then suddenly developed psychosis. Psychosis in a patient with epilepsy is often multifactorial. You identify it whether it is pre-ictal, maybe because there was an evolution or a change in the epileptogenic foci that is now presenting with an pre-ictal psychosis. Is it part of the ictal event? Or is it already a post-ictal event? So if it's pre-ictal or ictal, one of the ways to manage it is to count it as seizures. And so you have to up-titrate your anti-seizure medications. Of course, with every anti-seizure medication, increase in the dose of anti-seizure drugs, you have to watch out for any drug-induced psychosis. So there are several medications that are known to cause such. If it's post-ictal or interictal type of psychosis, then we have to manage it, even if the patient is pregnant. For the time being, there are really no clear reported cases of teratogenicity from antipsychotics. The most commonly used in pregnancy are olanzapine, quetiapine, and risperidone. Similar to the principle earlier discussed, it's just during the first trimester that you are most worrisome, because now you have to worry, is this mental state or psychosis is now harmful to the patient? So you don't want to reach to a point that the patient can harm themselves. So it's just really a balance.
Thank you. And in the interest of time, I will just take up one last question, and it's more on movement disorder with a comorbidity of dementia. So I'll request Dr. Vijay Sharma to take it up. Sir, the question is, why visual hallucinations are frequently encountered in Parkinsonism and dementia with Lewy bodies?
This is a very good research question. There is no agreement. There are a lot of hypotheses which have been given. There is a term called visual release, cortical visual release, cortical release phenomena which occurs in these patients. Some people say this is too much of visual information being processed in the occipital lobes. People say that this is probably related to an imbalance between cholinergic, glutaminergic, GABAergic pathways. And people say that even up to 70% of patients with Parkinson's disease at some point will have visual hallucinations. In the beginning, people say that Parkinson's patients, they enjoy these visual hallucinations because they are very mild. They usually occur in the evenings. There are some very peculiar things which have been described. There is absolutely no one single answer. There are a lot of theories about it. One of them is about the changing the levodopa preparations that is known to cause hallucination. But one thing is very, very clear. If a Parkinson's disease patient who was stable and then he starts suddenly getting visual hallucinations, then one has to look for alternative causes, like any kind of infections. It may be delirium. It may not be totally related to Parkinson's disease. And certainly you look for it that nobody has changed patients' medicines, because levodopa preparation, they are known to be associated. And it's said that if a person who is presenting something like a Parkinson's disease and he is having visual hallucinations very early in the course of disease, then one should consider alternative diagnosis instead of labeling this patient as Parkinson's disease. It should be probably, DLB, diffuse, Lewy body disease. That should be the first diagnosis of consideration. But it is a very interesting phenomena which happens. And in fact, if somebody is interested, there was a very good review paper a couple of years ago in a journal called ACNR, which was probably like 3 pages article, which I read, probably like 6 months or 7 months ago, which is just talking about all the hypotheses which are there, but it's not a resolved thing. You still need to just make sure like this. If these are mild hallucinations coming slowly, gradually, then consider these are a part of disease. If they come very early on, this is probably something else other than Parkinson's disease. If they come suddenly, exclude all other treatable causes like infections, delirium, and just make sure that somebody has not changed patient levodopa. This is the best which I can tell. A lot of people are working on it. And in fact, visual hallucinations have been one of the most attractive phenomena with the neuroscientists. But this is the best area for research. And most of them are formed hallucinations. So that's why people enjoy them in the beginning.
Thank you, sir. Thank you. I think it was a good question to conclude the panel discussion. And with this, we come to the conclusion of this event. And I'd like to take a moment to thank all the individuals who have made this event possible. Let me first begin with our very own Dr. Arvind Sharma, especially for crafting the theme of this event, crafting Neurospace as such, So without you, this event would never have been possible. So we are tremendously grateful to you for Neurospace. Of course, we thank our illustrious panel of speakers, starting with Dr. Vijay Sharma, who has always been the keynote speaker for Neurospace, and his presence is paramount to the success of Neurospace always. All other speakers who have joined us today, Dr. Geronimo from Philippines, Dr. Thar Thar Oo, Dr. Denise Pedra, Dr. Alejandro Ayaviri, and of course Dr. Bim Sara, who also joined us from Sri Lanka. So thank you all of you, and I think the gracious time you have spared in sharing all these cases and presentations is very useful to the audience. With that, I'd also like to thank the audience for investing their precious time, especially when they are in the extremes of time zones. I know some of the audience are beyond their dinner time, while for some of the audience it's early morning time. So we thank you for your generous participation, and I'm happy to share that we've had an overall audience of more than 500 doctors participating for this event throughout these 3 hours. So I think it's a commendable effort by the teams, our teams on the ground, who have ensured that these invitations and the agenda reached the right audience, and we were able to make this event successful. So before we leave, I'd yes, Dr. Vijay Sharma.
I just want to make a comment that I enjoyed the talk in Portuguese. It was a very sweet language. Whether you understand or not understand, very sweet flowing language. I enjoyed it.
Yeah. Thank you. Dr. Denise Pedra, if you would like to say something.
Oh, thank you for all. My English, it's not so good.
Thank you.
It was good in Portuguese. It was good.
Yes.
It was good in Portuguese.
Thank you.
Okay, thank you for all.
Dr. Arvind Sharma, you were saying something, yeah.
No, and I was saying thank you to all the speakers, and it was a wonderful interaction with all the speakers across the world, from Myanmar to Philippines to Mexico, right? I'm really thankful to all the talks the speakers has given, and day by day, the third one, I think we have grown more in different areas of pediatric epilepsies, dementia, and cases. And as usual, Dr. Vijay is always our pioneer to start as a opening person. Thank you very much to all, and especially, which Hardik you doesn't do, I should thank the Zydus team, whole from the corporate side, Dr. Hardik Gandhi, Sharad Patil, who they are all the behind the curtain people who has definitely worked so hard for this, and always they do. I thank them, and I hope the next year we will have the physical meeting with all our speakers and the participants. And thank you to the technical team for the flawless program which you have given to us from Zydus Corporate House, Ahmedabad. It's a beautiful place. When you visit, you will understand. Thank you.
Thank you, sir. And before I'll request the audience that before you leave this website, do visit the virtual exhibition hall, where you will find the partner booths and some resources on the science that was discussed throughout the sessions as resources in the lobby. And just before we leave, we would just like to show you a short video on a patient connect portal for epilepsy, which the physicians can use to enhance the care of patients with epilepsy. We are calling it the No More Epilepsy portal. And I hope to see you soon, and please take care of yourselves until we meet the next time. Thank you very much.
You.
Thank you, studio team. We can go offline now.